Hello, my name is Stephen Shoger. I'm the president-elect of OPA, and I want to welcome you to OPA's virtual webinar featuring Ashley Niemeyer, PhD, and Alexia Spanos, PhD. Both Dr. Niemeyer and Dr. Spanos are located in Bend, Oregon. Dr. Niemeyer is with the River Bend Psychological, and Dr. Spanos has her own clinic called Spanos Psychological Clinic. We're excited to have you with us here today, and we look forward to a fantastic presentation. Before we begin, here's a few housekeeping items. Our presentation today is conducted via Zoom, and it is being recorded as well. As such, sound and video will remain off so that attendees can enjoy the speakers and the learning material.
Kind of weird, isn't it? Yeah.
Questions will be sent via the chat feature for today's webinar. To ask a question via chat, please check the chat icon. You will have the option to send the question to everybody or privately to individuals. Questions will be collected throughout the presentation and answered during the Q&A portions of the day. Regarding continuing education, we are on a Zoom platform. A CE certification code will be provided at the end of the presentation, along with the link required for CE credit. OPA staff will be cross-referencing the survey evaluation form to the attendance list after the webinar is complete. There are strict guidelines on how participants are approved for virtual CE credit. Following the presentation, OPA will send a follow-up email containing the survey link. At the end of today's program, we will announce the verification code. Write this code down and save it. Following the webinar, we will email the survey with a section where you will need to enter the verification code. This code is required for requesting CE credit. We will give attendees 2 weeks to complete the survey. CEs will be sent out once OPA staff cross-reference the evaluation to the attendee list. Please allow 3 to 4 weeks for the certificate to arrive. Again, if you want CE credit, you must complete the survey and provide the verification code. Everyone must complete the survey. The survey will arrive in your box at the end of day today. With that, we'll start our presentation entitled Evidence-Based Practice in the Treatment of OCD. A quick introduction of our speakers. Dr. Ashley Niemeyer specializes in the treatment of anxiety and trauma in children, adolescents, and adults. Over half of her practice focuses on the treatment of obsessive-compulsive disorder across the age span. Dr. Niemeyer received her PhD in clinical psychology from Idaho State University, a program which focuses primarily on evidence-based practice. She then completed her pre-doctoral internship at St. John's Medical Center in Santa Monica, with a focus on psychotherapy and psychological assessment in children and adolescents in a community mental health setting. Following internship, Dr. Niemeyer worked at Children's Hospital of Los Angeles, CHLA, on the Project HEAL team, focusing on treatment of child and adolescent trauma. After CHLA, Dr. Niemeyer transitioned to private practice in San Diego, focusing on the treatment of anxiety disorders in children through adults prior to relocating to Bend. Dr. Niemeyer also completed the Pediatric Behavioral Therapy Training Institute, BTTI, through the International OCD Foundation in 2018. The BTTI is an in-depth 3-day intensive training course in ERP for OCD and includes follow-up consultation and supervision prior to completion. Dr. Alexia Spanos specializes in the treatment of obsessive, compulsive, and related disorders, anxiety disorders, and trauma for adolescents and adults. She also specializes in the treatment of eating disorders across the lifespan. Dr. Spanos has more than 10 years experience treating individuals with obsessive compulsive disorder in individual and group therapy through volunteering with the Seattle OCD and Hoarding Disorder Support Group. She has also completed the Behavioral Therapy Training Institute, BTTI, through the International OCD Foundation in 2014. Dr. Spanos obtained her PhD in clinical psychology from Michigan State University and completed her predoctoral internship at McLean Hospital, a Harvard Medical School affiliate. She completed her postdoctoral fellowship at the Evidence-Based Treatment Centers of Seattle, that's EBTCS, where she completed dual training through the Anxiety Center and the Eating Disorder Center. Before moving to Central Oregon in 2020, Dr. Spanos was a staff psychologist, director of training, and most recently, co-director of the Eating Disorder Center at EBTCS between the years of 2014 and 2020. Please join me in welcoming Ashley and Alexia this morning.
Is that over to us? All right. Welcome, everyone. So the talk title, as you know, is Evidence-Based Practice for Obsessive Compulsive Disorder. And I'm just going to give you kind of an overview of what we're going to go over today. So real quickly, we are just going to give you some education about OCD. We're really going to highlight the different subtypes that maybe are a little lesser known, because one of our goals here is that you can understand and identify some of the more rare types of OCD. We're going to go over education about the theories and models of OCD, etiology, things like that. Then we're going to get into the meat of our talk, where we talk about education about ERP, what it is, how to do assessment, how to do psychoed treatment, and then give you some case examples. We're going to talk about your role as a therapist in administering ERP. And we're going, in that part of the talk, we're going to have small group discussions, some vignettes, some things for you guys to do, and have some small group activities for you. We're also going to get a little bit into some specialty populations, but because of time constraints today, we're really just going to focus on children and adolescents. Just a couple comments. The good stuff is really in the second half of this talk. And what I mean by that is, in the second half of this talk is where we get into the content about the therapy. We have more room for case examples, more room for breakout groups. So we're going to go a little quicker in the beginning. If we're glossing over something when we're going through theory, and we're going through some research, and you have questions, put them in the chat and we will get to them. But just letting you know that there may be more content on the slides than we actually cover, because we're trying to get to the good stuff. We have done this workshop before, but we did it in person. So be patient with us as we try to adapt some of the things we've done in person to this virtual format. And then note my little emojis here. One of the hard things about doing this virtually is that both Alexia and I do well when we're getting feedback from our audience. So smiling, nodding, laughing. We don't have that here. We just have black screens. So feel free to put feedback in the chat or respond with those little emojis that you can do at the bottom of Zoom, where you can go in and you can, you know, if I say raise your hand if, or if you put a little emoji just to let us know how we're doing. It's good for us to have that feedback. We appreciate those comments and questions. So we're going to have time for those comments and questions, I believe, every hour. So keep those coming in the chat, because one of us will be also monitoring, and it's good for us to know. Okay, well, let's get into it. So first thing here is, you might be wondering, why is this talk important? If you don't specialize in treating OCD, why are you spending 5 hours here learning about it? And are you going to walk away from this 5-hour talk knowing how to treat OCD? First of all, not necessarily. What we hope our goal is that you're going to walk away from this talk better understanding the different types of OCD, not to misdiagnose or miss OCD and interpret it as something else, and to know a little bit about treating it, or to know when you're over your head and you might need to refer out, or to understand that this is really interesting to me and I want to get a little bit more consultation and start doing this work. If you're already doing this work, great. That's great. You're going to get more information here about the new research, etc. So why is it so important? First of all, it's typically one of those diagnoses that is underdetected and underdiagnosed. They've done research where they show case examples to doctoral level practitioners, and up to 50% of OCD cases are missed. And certain subtypes are even more likely to be misdiagnosed. For example, themes related to sexual themes, aggression, or religion. Everybody really knows when they think about OCD, they think about symmetry, they think about contamination, germs, but there are so many other nuanced types. They did a research study, the Brown Longitudinal Obsessive Compulsive Study, that was really shocking. And I hope if they redid this, that the findings would be different. But what they found is it took an individual with OCD up to 17 years to access the correct type of treatment. And even then, only about half of those people were receiving CBT, which might mean ERP, but it might not. And so we see this a lot. I don't know about you, but we see this a lot in our practice where people come in who have been in therapy their whole life, but really have never accessed ERP. In fact, I was just this week, I had a patient tell me that she had spent so many years in therapy and she felt like her therapist was just engaging in her rumination with her and going in circles and really reinforcing a lot of her her OCD themes without intending to. So this is really, really important because I always say with a lot of types of therapy, good therapy is good therapy. But with OCD, sometimes trying to be reassuring and kind and supportive can actually inadvertently make the OCD worse. Another note is that in inpatient settings, patients hospitalized with some kind of anxiety disorder are most likely to have OCD. So it's something that either is not getting not getting diagnosed, is not getting the right treatment, and is also more severe than other anxiety disorders. So we really hope that you walk away from this with learning how to identify those patients and either provide them with that right treatment or refer them to someone who can. And that's our goal. So we did have a little poll, and now we get to the technology, because when we did this workshop, we just said, raise your hands and tell us. I think our supporters here are going to give you guys this poll, and I think they're going to give you actually two different polls in one. I'm not sure where you guys landed, but we want to know a little bit about where our audience is in terms of your experience treating OCD. Would you refer out if you see a client with OCD? Are you trained in ERP? Do you use exposure therapy in general? Not ERP, but exposure therapy in general in your practice. And I did not include this in the poll, but if you don't currently use ERP, what types of therapies do you use to treat OCD? And you can just put that last question in the comments in the chat right now. But I'm going to turn that over to you guys if you want to administer the poll, if it is going to work. There you go. Great. So you're going to see that there is a second poll, and we're going to go over those results later. But go ahead and fill those out, because the second part is asking what types of OCD have you worked with. So go ahead and endorse that as well. Not yet. Yeah, and like I said, in the chat, go ahead and once you finish the poll, write in there if you don't use ERP and you have clients with OCD, what interventions are you using? Because we're going to talk about different approaches to treating OCD at the very end that are not ERP. Yep, ACT, good answer. We're going to talk about that. This is really interesting. It's like 100% of people treat OCD and 90% will refer. So this is confusing. Yeah. Uh-huh. Let me see. Yeah, and I see a comment about intrusive thoughts without compulsions. We're going to talk about that pure O and what that means as well. So if I'm reading this right, and Alexia chime in, I'm just trying to quickly interpret data, but it looks like a lot of you do have experience with ERP and experience with OCD, which is great, which means when we're going through some of this, if you want to chime in and ask deeper level questions and we can get into that, please do. Is that how you're seeing that?
Yeah, and we also got a comment that referrals depend on intensity of symptoms. So that might be some of what we interpreted as a little discrepancy between people treating OCD and referring out. I think it sounds like if it's not as intense, then it might be something that we'll do in office.
Right. When we did this workshop before, what came up was that a lot of people came up to us afterwards and said, things that I thought were just anxiety, now I'm realizing were OCD. So it'll be interesting to see at this talk what you guys are viewing as well. Okay. All right. And then again, this is really, I'm just going to jump into the second poll, that 81% of you said that you have worked with contamination OCD, but a lot less of you have worked with the other types of OCD. 41% with harm OCD, and then below 40% on everything else. So the hit and run, sexual taboos, et cetera, et cetera. And that's pretty typical, I'd say, of general population. I don't think that's typical of what we see.
Yeah. I think we see a lot more of the scrupulosity and sexual taboo stuff.
More of things that are
and
not
harm.
typical OCD. Okay, great. So moving on. Oh, I can share the results. Should we share that? See, this is what I say, be patient with me here.
That's so cool.
Okay, so I don't know if you guys can see that, but I went ahead and shared that. So if you want to scroll through it and look at it really quickly, and then we'll move on to the next.
I think you're sharing your view. So you're the one scrolling, maybe.
Oh,
I don't know.
I don't know.
Can't tell.
All right, moving on, everybody. Okay, so what I want to start with is that OCD thoughts can sound really weird. I really, really cannot highlight enough that a lot of times people with OCD have shared these thoughts with a therapist or a family member or a friend and have been judged or misinterpreted in some way. So here's some examples of OCD thoughts. What if I just stabbed myself in the eye with this pen right now? What if I did that? What if I killed my mother and I don't know that I've already done it? Do I secretly want to hurt this baby? Do I have intentions and desires to hurt this baby that I'm holding? I'm not sure if I turned off my hair straightener. Is that because I secretly want to burn my house down? I think a lot of people think about checking, like turning off a hair straightener, but they don't think about the intention. If I breathe in this scent, something bad will happen to my body if I let the scent into my body. And why can't I stop thinking about cheating on my husband? Does that mean I don't love him? But even though these thoughts might sound bizarre, they might sound odd out of context, we all have thoughts that sound like OCD. We all understand the concept of having weird thoughts. It's just that what we do with them decides whether it develops into OCD or it's a fleeting weird thought. I always give the example to clients and to parents of clients with OCD of what if I just jumped off this chairlift right now? Because how many of you have been on a chairlift? And I don't know, I have. Sitting like, I just jumped off. There's nothing stopping me. That's terrifying. Doesn't mean I actually have harm OCD.
Right.
A good example, as opposed to, did I kill my mother? Do I want to kill my mother? I just had a thought about my mother dying. I'm not going to think about it. It's not going to happen. Let me just think about something else. So a good example of doing something else with the thought rather than obsessing about it, you just throw the thought away and move on. Everybody has had the thought about, what if I drop this vulnerable, adorable baby? Or what if I touch the soft spot on their head? What if I push on that thought and then the spot on their head? It is a normal thought, but most of us move on and refocus on how cute the baby is. Did I lock my car? How many of you have had that thought? But it is not the same as, did I leave it open because I want it to be stolen? As opposed to thinking, if I breathe in the gross smell in the restroom, something bad will happen to me. A lot of us think, let me not breathe that in. And then it's a very common thought to think about finding somebody else attractive. These are normal thoughts that people have. However, I'm not going to go in depth about the DSM diagnosis here, but what makes these normal thoughts turn into OCD is what people do with it. So when you're doing the diagnosis of OCD, you're looking for these two different categories. You are looking for the presence of obsessions, so recurrent thoughts that you do not want, that you tend to try to ignore or get rid of, rather than just saying, oh, well, that was a weird thought, I'm going to move on. These are thoughts that cause you distress and you get stuck on. That's the obsessive part. The compulsions really are just, what are you doing to get rid of the thoughts or the uncomfortable feelings? So when you're diagnosing, you're looking at those two parts. You are also looking at how much time are they taking up in the individual's day, or how much distress are they causing that individual. So sometimes it's not taking up very much time, but it's a lot of distress. Other times we see people that this is taking up hours upon hours of their day. So remember that you're looking at those three components. I'm not going to go into more detail on that because we're going to go over the different subtypes in detail. And then I'm going to hand it over to Alexia.
So the exact etiology of OCD is unknown. This is not unusual. This is kind of what we get in psychology. But we do know that there is a significant biological and genetic component. And I'm not going to go into more detail than that. I think most of you already know that information. I think the most important part to highlight on this slide is that for a lot of clients, a lot of them will say to you, I have these thoughts, I have these fears. I kind of know they don't make sense totally, because a lot of them do have good insight, but it feels so real. And the reason why it feels so real is because their amygdala is actually activated when they have these OCD thoughts or urges or images. So that's a point to be able to validate for a lot of our clients. So OCD involves both classical and operant conditioning. The way we think about this is that at some point there's biological or genetic vulnerability that makes your brain more sensitive to uncertainty. Then someone's confronted with a cue, they feel anxious, and then the next time they encounter this cue, they might feel anxious again because now that cue has been paired with the feeling of anxiety. So in an attempt to rid themselves of the anxiety or discomfort, a lot of people, in the case of OCD, of course, will engage in rituals or they will seek reassurance. And it works. They feel better. So they're more likely to do it again in the future when they encounter that cue again. So what's really interesting about OCD is many times it begins in sort of a subtle way, but it can escalate really quickly because their use of rituals or reassurance gets reinforced so quickly in that moment. So I have a quick example for you. I don't have OCD myself, but since I started learning about OCD in graduate school and then treating OCD, I make a point to really remember a lot of my intrusive thoughts so that I can share them with clients when I have them. And one that I had that started in graduate school was the psychology building was about 10 minutes walk away from where we were allowed to park, because of course it wasn't at the building. And I would have to walk over this very small footbridge with a little river underneath to get from the parking lot to the psychology building. And one day, as I was walking over this footbridge, I had this image just pop into my head of myself doing one of these like one-handed double leg jump overs the bridge, which there's no way athletically I'm capable of doing. But I had that thought. And I just remember thinking, gosh, that's so weird. And oh, it's all iced over on the river below. What a weird thought to have. And I forgot about it because I don't have OCD. But then the next day I walked across the bridge and I remembered having the thought the day before. And I remember thinking, remember yesterday when I had that weird image? So I had the image again. And now it's been 25 years later, every single time I walk over a bridge, I have that image pop into my head. So it's become cued or paired with just the experience of walking over a footbridge. So this is a graphic to depict what I just described. So somebody, we start at the top, and somebody has an obsessive thought. It causes them a lot of anxiety and discomfort, right? This is one of the areas where, in my case, it differs because I wasn't anxious about having this thought. And the person wants to get rid of the thought. So they engage in a compulsive behavior. They feel a great amount of relief. And then that compulsive behavior has gotten reinforced, which means next time they encounter that same obsessive thought or cue, they're more likely to engage in the compulsive behavior again. In the case of OCD, thought interpretation and thought suppression are also really important components of learning. So it's not actually the thoughts that differ for people with and without OCD. It's that a person with OCD interprets the presence of these thoughts differently. There's been really cool research studies done where they take two groups of participants, one with diagnosed OCD and another group without OCD, and they asked them over the last 2 weeks, tell me all the weird, bizarre, unwanted, inappropriate, upsetting thoughts that you've had, thoughts, images, or impulses that you've had. And everybody writes it down. And when you take those two lists and compare them, they actually look identical. So the content of the thought doesn't differ at all. But it's the fact that people with OCD have anxiety about having these thoughts, and so they want to suppress them. This is a quote from Jonathan Abramowitz, who is one of the big names in OCD treatment. He says, the average person has about 4,000 separate thoughts in a day, and for almost everyone, OCD or no OCD, some of them are intrusive and unwanted. But when we actively try to suppress our thoughts, we actually think about them more, right? So there's the exercise of try not to think about a red balloon. And when you say that, of course, people start thinking about a red balloon. If you then tell someone, think about a red balloon and don't think about anything else, more than likely within a few seconds or minutes, their mind is going to start to wander onto something else. And this actually forms the basis for imaginal exposures in OCD treatment. And here's what it would look like. So this is the same graphic as before, but in this case, this is where the interpretation of the intrusive thought comes in. It's the presence of the thought, interpreting the intrusive thought as problematic or meaning something that it may not mean. Like, the fact that I had this thought is so horrible, it must mean I'm a bad person. That causes anxiety and discomfort. And then in an attempt to suppress the thought, they will engage in compulsive behaviors. Here's a list from one of those research studies that I mentioned of intrusive thoughts that are reported by people without OCD. So I'm going to read just a couple of them. Sudden urge to kick a baby, thought of putting the cat in the microwave, the image of my mother dying of cancer, the thought of my best friend committing suicide, thought of being poked in the eye by an umbrella, the impulse to shout obscenities. And there's one I can't see on the bottom of this, but it's thoughts about having sex with ugly people on the bus. That one always gets a laugh from people in the room.
Yeah.
Yep.
Mm-hmm.
I remember it though, because it's so
Mhm.
notable. Okay. Another core component of OCD is uncertainty, or a fear of uncertainty. So OCD lives in the what ifs of your mind. And OCD will choose to accept uncertainty in certain areas of one's life, but not in others. So whereas OCD might say, you know, it's fine, you can eat food at restaurants, and, you know, it could be poison, but you can eat it, it's not a big deal. And it chooses to accept that uncertainty. It might actually decide, okay, but having the thought I might stab my spouse is not an area of uncertainty I can live with. So instead, OCD will pick certain things and will make someone want to be 100% certain that they think the thing they fear will not happen. But that's impossible because nothing is 100% certain, right? Do unicorns exist? Probably not, but we don't actually know with 100% certainty. We can't say that. Just because nobody's ever seen them doesn't mean we can know with 100% certainty. Is my daughter alive right now? I hope so, but I'm not sure, right? She's at school. Maybe in the last 30 seconds since I've been speaking, she had an accident at school and she died. So I wouldn't know that just sitting in this room right now, not being with her. And even examples like, will the sun rise tomorrow? We don't know that for 100% certainty. I mean, if you asked me to bet money on it, I would bet a lot of money, but I still couldn't give you that 100% certainty that OCD is looking for. Jonathan Grayson, in his book, Freedom from OCD, does a really good job of highlighting this uncertainty as a core component of OCD. And he says, the past is a memory and the future is no more than a hope. We make plans for tomorrow, not because it will come, but because it might. And if we make no plans, tomorrow will be beset with a host of problems. So I like this idea of kind of grounding us in the, yes, we do have to plan for the future, but we can't assume it's 100% certain. Okay, so this is another slide I'm going to try to gloss over because it's not as exciting as some of the later ones.
Poor Alexia gets all the background information slides.
It's okay. I read the 27-page paper by Michelle Krask, so I feel like I have to do this now. So the prevailing theory up until relatively recently was that ERP, we know that ERP works, but the thought behind why it works is because of habituation. And habituation is the idea that the longer you stay in the situation, your exposure, the situation that you fear, your anxiety will go down. And in here, they would highlight, the theory highlighted that you have to keep somebody in an exposure situation long enough for them to say that their subjective units of distress scale, or SUDS ratings, would go down. And then it was also really important to see that there was between session learning as well. So we would often ask clients throughout the session, what are your SUDS? What are your numbers? How anxious do you feel? I still do this. Ashley still does this, but we're not doing it exactly for the same reason we used to because of habituation. We're usually doing it to just kind of gauge, are we doing a good job planning the exposure?
And for the learning experience for the client that, hey, I actually came down maybe from a 7 to a 6.5.
Right.
That's cool.
Right.
Yeah.
But even if they don't come down, that's okay, because learning still happens. So on the diagram on the left is a within session exposure trial. And you can see that what you're doing on the red line is basically says, stay in the exposure, don't do your compulsions, and your anxiety will start to go down. On the right is over multiple sessions of exposure. And you can see that not only does your anxiety go down within the session, but between sessions of exposure, you're also seeing less of a maximum anxiety point there too. Okay, then Michelle Krask and a lot of other brilliant people at UCLA found that the habituation model was not quite capturing the full picture that we were seeing in ERP for a couple of reasons. First, some people will just say they don't experience fear going down. They don't experience habituation. And I believe them. I have actually had very few people say this, but I do believe that some people will say, yep, my anxiety stays high the whole time, or it stays higher than maybe they would want it to. But they were still getting better, even when they were saying habituation wasn't happening or we weren't seeing it happen. We also can see a spontaneous return of fear after treatment ends. So sometimes if too much time has passed since treatment, or after an adverse event. So for example, I fear flying. I still do it because I want to go places, but I really don't like it. And mostly what I fear is the turbulence because of the plane crash, my belief that the plane will crash. During COVID, obviously didn't fly for many years. The very first time I went back on an airplane, I'm not even kidding, I actually started sobbing within the first like 30 seconds. There was turbulence. Yeah. Because it had been so long since I'd been on a plane. So that is a spontaneous return of previous fear. And then some treatment responses were not generalizing to other contexts, meaning if we were doing exposures in our office, sometimes people would go home and they weren't seeing the same progress at home. So Michelle Krask and colleagues updated our understanding of why ERP works with something called inhibitory learning theory. And basically the idea is that inhibitory learning theory states that rather than erasing old fear-based learning, exposures create new learning in the brain. Okay, I'm not going to go through this interview, but I put it here for you guys if you want to listen to it, because I think it's a really good interview. Okay, so this is what it looks like. This is the previous theory said, here's the fear pathway, and the goal is erase old learning. We realized that wasn't happening. Instead, the updated theory says, here's the fear pathway, and now we're creating new learning, a new learning pathway in the brain. And with enough repetitions, we can make this new learning pathway stronger than the old pathway. But the old pathway is still there, which is why we would see spontaneous return of fear. Okay, so the most important thing, the reason why all of this is important and this updated theory is that when you're planning an exposure and when you're doing exposure with clients, the most crucial question you need to be asking is, what does the client need to learn?
And I would say what I like about inhibitory learning, and when it first, I still remember when it first started coming out,
Yeah.
and I was like, why are we messing with this?
Right.
This is complicated, confusing.
It's very complicated.
We
Yeah.
understand habituation. Let's leave it there. But what I love about it is it's actually more fluid.
Yes.
It's saying, hey, we don't need to follow such a structured, the client's SUDs have to decrease by 50% before you
Right.
end the exposure.
Right.
And then you're in this hour and a half long exposure and the client's still anxious. They're saying, just do the exposures, do them in lots of different contexts, do them with different cues. And the client needs to learn a new belief that inhibits the old belief.
Right.
So that new belief might just be, I can tolerate this. And their belief before was, I can't tolerate this. The belief doesn't have to be, I'm not scared when I'm holding a spider in my hand. It can just be, I can hold the spider in my hand and I will not die.
Right.
And that's okay. So I think like when I remember sitting in, I think it was in a BTTI and they were talking about inhibitory learning and the presenter was like, there's this stuff, it's complicated. And I was like, I don't want to go there. But I really actually love it because it's freed us up a lot. So I hope, and this is something you guys can ask questions about if you want to know more, but I hope that you guys have the takeaway that that takes away a lot of the structure and manualization. It gives us more flexibility and creativity in how we do our exposures. So, yeah.
Agreed.
Okay.
I think we should keep going.
Okay. So we're going to switch and we are going to start talking about the different subtypes of OCD. And I love this quote, which is, OCD is as limitless as the human mind. So if you can think it, it can be OCD. And I still just currently am working with a client that keeps surprising me with things I've literally never heard of before. The thing is that once you know OCD and you smell OCD, it doesn't matter what the theme is. And you're like, yeah, it smells like OCD, right? But there are so many types. And I love this because Alexia, when we put 3 slides together, she wrote, I think it's Jonathan Abramowitz.
And I went back to try to find it and I couldn't, but I was like, it's a good enough quote. I'm keeping it in there.
Yeah. So if anyone knows, feel free to put it in the comments who actually said this, but that's what we think. So, okay. So I really like, if you walk away with one thing from this talk is that OCD is not just being clean. In fact, a lot of people with OCD will get angry about that. I had a teenage client give a lecture to his health class about how OCD is not just about being clean. I was so proud of him because it's really not just about that. And in fact, to me, that's the easiest type of OCD to treat is when it is about being clean. And it's the other types of OCD that don't get the right treatment. So we're going to take the time and go through these subtypes. And I really do want you to ask questions about this when the break, if you have questions about this, because this is an important takeaway for you that you can start to smell OCD and see it and know, oh, this might be OCD. So the following list is not comprehensive. Ironically, when I was putting this together, I pulled from different articles, different books, and no textbook or book or article has the same list of types of OCD. And that's because there's so many of them and because it's not in the DSM. And so there's no like, these are the 6 subtypes of OCD. It doesn't work like that. So there's likely other types that I haven't even put in here when I was putting those slides together that are OCD. The important thing to remember when you're trying to figure out, is this OCD, is that you need to focus on the fact that those thoughts are distressing. So remember, Alexia said, how do you interpret it? Do you interpret those thoughts as distressing and bad, as well as there has to be attempts to eliminate the distress? So those compulsive behaviors have to be present. this is the poll we talked about. And interestingly, it does support what we would expect, is that most of you have seen or worked with contamination OCD, but less of you have worked with the other types. And that's pretty typical. It may not be that you haven't worked with it. It may be that you didn't see it. I don't know, right? Because people sometimes are a little more hesitant to share some of these as well. So here's the first one. This is the most common, known about, this is what's portrayed in media, is contamination OCD. But I want to highlight that everybody thinks of contamination OCD as being about germs, getting sick, gross things. And it's not just about that. It actually can be about things like being contaminated by the essence of somebody else, or spreading your essence to somebody else. So if I believe that I am a gross and bad person, I wouldn't want to sit too close to Alexia, because then you are going to become contaminated by me and become a gross and bad person. Another one that I see a lot of is the sticky substance one. I don't know if you do.
Yes. Yeah.
So you might have a client who is washing their hands over and over and over, and you make the assumption that they're afraid of germs, only to find out they're washing their hands over and over and over to make sure there is no soap left on their hands. Other things that come up that are interesting about medication. So the fear of being contaminated by the side effects of a medication, or being injured by medications. And you can see how that is a problem when you are trying to get your client with severe OCD to take their medication. So,
and I've had 2 or 3 clients actually who were afraid of accidentally ingesting illicit drugs. So it has to do with packaged food, unpackaged foods, who's preparing the food for them, where they got it, what kind of restaurants, the kind of people that work at those restaurants. And it even extends to medication, because there's a fear that there was tampering of some kind in the lab, or in the supermarket, or something like that, or at the pharmacy.
And this will be people in the grocery store who are inspecting packaging to make sure it's not dented in some way or looks odd, because then it may be contaminated. And it makes me think of that meme that I saw right before Halloween, where it was like a picture of drugs and candy, and it said, look, nobody cares about your kids enough to give them expensive drugs. But yet people will obsess over that. Okay, so this next one, and funnily, I can't see my topic, is harm OCD. And so harm OCD, I kind of encapsulated multiple types here, but basically harm OCD is the fear of harming yourself or harming somebody else, or the fear that your actions inadvertently will cause harm to others. So a lot of people think about this fear of people who have to check the stove before they leave their house, I hear hair straighteners a lot. Like,
yes,
people have more time than me because I don't straighten my hair that often, but checking
curling irons also.
Yes, curling irons, whatever.
Yep.
But also people who cannot leave a single light in their house plugged in at night, or nothing can be near another light or a plug, because it might cut. So you hear about that a lot, and you've probably heard about that in your practices. But what you may not get is the fear is, I'm secretly deep down a bad person who wants to burn my house down and kill everyone in it. And that's why I have to check, because I could not live with the possibility that I secretly wanted to do this. And I left all those appliances plugged in on purpose and let the house burn down. And this is really painful. So you see people engaging in so many checking behaviors, so much avoidance. When the Dahmer TV show came out, none of my clients could watch that, because they're like, if I watch it, I might become him.
Yeah.
Checking to make sure that you lock the door is because maybe you want them to break in, or maybe you're afraid that they will. And this gets so bad that it is not just checking multiple times. I have clients now, technology is terrible, where they're taking pictures or videos of the door and then going up to their bedroom and reviewing it to make sure that that door is locked. Okay. I encapsulated hit and run OCD into this category, but a lot of times you'll see it as its own category. And hit and run OCD is really debilitating. This fear that you maybe hit somebody with your car and don't know that you did. And so this means people take a long time to get anywhere, because they're going back over their routes over and over, literally looking for a body on the side of the road, or inspecting their car for scratches, for blood, et cetera, et cetera. And oftentimes I think this can get misdiagnosed as trauma or agoraphobia or something like that, or well, we'll talk about other things, but this one is can be its own category in and of itself. And I will also say there's a lot of reassurance seeking. I'm not a bad person. I wouldn't do that. Okay. I'm just checking our time. We're good. Scrupulosity is sometimes talked about as religious themes, but it's really more about morality and the fear of being a bad person, and the fear of, it can be religious in terms of being sinful or blasphemous, but really deep down, it's about your own morality. So a lot of obsessions like, why did I think that? That's a bad thought. It's an impure thought. It's a sacrilegious thought. There's this feeling of needing to be perfect in your religious beliefs, which I find kind of interesting philosophically, because if you think about what faith is, it's having faith without being perfect and without knowing for sure if you fully believe something. But if you have OCD, you need to be 1,000% sure that I truly believe this and that I truly am a good person and a pure person. Sometimes it can include fears of things that are very religious related, like possession, the devil, hell, etc. There's a lot of checking with others about your faith, a lot of excessive prayer, which I find really sad, because prayer is supposed to be a calming and helpful and special, meaningful thing, but it can become contaminated by OCD, where prayer has to be perfect and there's hours and hours of prayer. And then engaging in activities to prove your faith, which you might think is things like donating to charity, but it literally can be a thought in your head. If you don't stand up right now, it means you don't believe in God. So you have a person who is standing up all the time to prove their faith. So, and then mental rumination over your own morality. How many of you guys want to spend hours ruminating over your own morality? That is not a pleasant place to be. Yeah. Okay. This is really important. And I threw all these kind of more taboo themes together into one category. Again, they could all be separate categories, but for time's sake, here we go. This is one where I think that people sometimes can experience judgment, can experience shame, are afraid to bring it up. In fact, sometimes people don't bring these themes up with me, especially teens, I think, don't bring these themes up with me till a couple months in or 4 sessions in, even though I've expressly asked about them. So the obsessive fears can be questioning your sexual orientation, your sexual identity, your gender identity, intrusive and inappropriate sexual images. I don't know if anyone has seen the show. I think it's on HBO called Pure. Have you seen it?
No.
Oh, you have to go watch it.
Okay.
I recommend it. It's a great representation of sexual obsessive OCD. But if you are easily offended, do not watch it, because all of her intrusive sexual images are just within 5 minutes right there on the screen. And so she's at a wedding doing a speech, and suddenly she pictures all the wedding guests having this pornographic sex with each other, including family members having insexual sex together. And that is what it is like to live with this fear. So it's fears of being attracted to inappropriate people, like family members and children, fear of cheating on your spouse, fear of being attracted to your teacher, your boss, etc., or just someone you're not supposed to have sexual feelings for, and questioning, if I had that thought, would I act on that thought? Questioning if your partner is right for you. I mean, raise your hand. We have all questioned that. But if you have to spend all day, every day wondering that, and then wondering, remember, interpretation of thoughts, why do I think that? If I think that, does that mean I don't love my partner? The compulsions involve avoiding places, and this is really sad. So people who don't go anywhere where there might be children, or they avoid their own family members. I've had kids who do not want to be close to their father, for example, because they're afraid of attraction to their father. And it gets to be really, really painful and really, really sad. Seeking reassurance from others that you won't act on these impulses, like asking your own husband, you don't think I'd cheat on you, do you? This gets really hard in relationships. And then also people get into this testing it out thing where they're checking if they're aroused by certain things. And the body is a weird thing. So sometimes there will be an arousal response, which then confirms for the person that in some way they're a bad person.
There's a great short article on the International OCD Foundation website. The title of the article is "Did It Move?" And it's based on an episode of Seinfeld where George Costanza goes to a masseuse, and
Yes.
he's male, and he starts questioning, did his penis have a reaction? Did he get aroused? But the article is actually very well written. It's really good. It's a really good.
You will learn, and we'll start to share more of this as we go, that OCD therapists have a strong sense of humor because we are always talking about very inappropriate things.
Yeah.
And it's just part of our practice. You talk about poop, pee, semen, you talk about people's sexual urges and what's normal, what's not normal, and you just have to be really comfortable. Thank you for someone giving us emoji there, because here we are talking about extremely inappropriate things, but you have to desensitize, and we're going to talk a lot about that, how you have to approach that.
Right.
Yes.
Right.
Okay. I think what I'll do is do this one last slide, and then we're going to take a break.
Yeah. And then we play the video.
And play a video after the break. Okay. So this is just my attempt to do like a catch-all kitchen sink. Like, here's some other types. And again, some of these are pulled from books. Some of these are pulled from my experiences, etc. But just right OCD. This is another one that I think people think about a lot. They think about OCD being perfect, but they think about it in terms of cleanliness or symmetry. But it can be anything. It can be rewriting the letter 6 until it looks, the letter 6. Oh, I'm winning today. The number 6 until it looks like the perfect number 6. And it's seeking a sense of perfection and correctness. It can also be very similar to repeating OCD, and sometimes it's hard to distinguish, and it doesn't really matter, splitting hairs. But repeating OCD is repeating actions until they feel right. So imagine trying to get in and out of a car. This is really painful for people for 25 minutes until it felt like you got out of the car correctly. One I see a lot is rereading, rewriting, or reviewing things. And this is really painful because it means that a lot of, I've had college students who've dropped out of college because they're rereading things so much to make sure they fully understood it. Or people who don't read for pleasure anymore because they cannot get off one paragraph. And that's really difficult. Symmetry OCD is needing things in the environment to be balanced, but it also can be needing things on your body to be balanced. So if I were to bump into Alexia, I would need to bump into something else with my other arm to balance that feeling out in my body. So that feeling in my arm that bumped her needs to now bump my chair. So I have the exact same balanced feeling on both sides of my body. Reassurance seeking or confessing, it's not necessarily its own type, although with kids, sometimes I feel that it is, where they just spend hours confessing their bad thoughts and seeking reassurance from others, usually parents or spouses, that their fear doesn't mean that they're a bad person, or that it's okay that they thought that, or it's okay that they did that. Superstitious or magical thinking OCD, this is the don't step in a crack, you'll break your mother's back type of thing. And so I have wooden floors in here, and I've literally seen people try to not step on any of those lines in the floorboards getting to my couch, and it's quite a long ways from my door. But it can be anything. It can be I need to swallow 3 times so my mom doesn't die. I need to blink 16 times so I have a good day today. These kind of things. Existential OCD is really complex and hard. And I think sometimes it comes out at the end of treatment too, where people start questioning everything. Like, what is the purpose of life? Do I really have OCD? What if I don't have OCD? What does it mean to feel this way? Am I alive right now? And it's really easy as a therapist to get caught up in that. And then lastly, I'm not going to talk too much about this, but I want to say this because somebody mentioned in the chat, pure OCD. There was a belief that, and there probably still is, that there can be pure OCD, which is there's no compulsions at all. But I would say most of the field now says that, yes, there is pure OCD that exists solely in your mind, such that you're not, tapping your pen 6 times, you're not washing your hands 16 times. But you would argue that these people that are doing everything in their head are still engaging in compulsions. It's just that they're thinking about things over and over and over. So those thoughts and those ruminations become the compulsions. So I tell my clients with this, when you are thinking about this one fear for 45 minutes, I want you to picture it's the same as washing your hands for 45 minutes until they begin to bleed. It is the same thing. You're just doing it in your head, and it's causing the same level of distress. So I think we'll leave it there and take a break. And when we come back, we have a little video to show you with examples of some of those types.
So I think we're coming back at 10:05.
Yep. So we're supposed to give you guys about a 10-minute break, but we thought we'd open it up if anyone has some questions as we ease back in. So if anyone, I mean, well, actually, I think you guys are moderating those questions, but I don't think we've seen any yet. But so if anyone has any questions at this point during the break, you're welcome to put those in the chat and we'll answer those. And then we'll start back up in a couple of seconds, couple minutes.
That's correct, Ashley. Nobody has yet put anything in the chat, but please feel free throughout the day. Don't have to wait until the end, and we will kind of collect them and ask questions during the breaks.
And you guys are all like straight A students because you took me seriously when I said, give us some feedback, and so we've been getting some direct messages about how things are going. And that's really helpful because like I said, we are talking about sensitive content. So it's really helpful to know how this is landing with everybody.
There were a couple of questions in the chat, one from Jacob talking about in a pediatric medical setting, talking about the autism versus OCD.
Thank you. Actually, glad you highlighted that because we are going to talk about that at the end when I talk about children, because that comes up a lot and it's really nuanced and it's hard to make that differential. And I get a lot of referrals. Alexia doesn't work with as many young kids, but I get a lot of referrals for OCD that turn out to be autism. Not as much the other way around, weirdly, but it can happen both ways. But people say, my daughter has OCD, and it turns out she does not. So looks like we do. Christine, you had a question?
Yes, hi, can you hear me?
Mm-hmm.
Yeah, I was wondering if you could, thank you so much for providing us this background so far. I'm wondering, in your clinical experience, do you see like in terms of like a subtype of, or like, you know, in certain populations you have like this emphasis on the wellness culture, like presentations of people like doing, like having obsessions around like the chemicals or things have to be organic. And I know there's like definitely probably some overlap between like orthorexia and that kind of stuff. But I could also sort of see, at least in certain, you know, populations, that, you know, even like their social circles really kind of contribute and exacerbate.
Yes. Oh God, yes, sadly. I'm gonna let Alexia take it because that's her specialty, but 1000% yes.
Yeah, it does come up quite a bit, and it's actually interesting that you mentioned orthorexia because right now I have two clients, one who has primarily OCD and the other one who, they both have OCD, but one has a lot of eating disorder stuff overlapping and was in residential program for eating disorders last year. But both of them have this sort of toxic foods, pesticide, bad chemicals. And you're right, it completely, the culture around us kind of feeds into that, both from a diet perspective and a sort of fat phobic perspective, but also because of this fear in OCD. And so I see a lot of that. And you just, you know, one of the first sort of strategies in OCD sometimes is just kind of do a little bit of a checking the facts. And so we do our research together before, I don't let them go off and do research on their own, but I'll do it with them. I'll be like, well, this is where the truth lies for this particular thing. And I even had a client recently have to tell her colleagues at work that she needs to kind of disengage from a conversation about toxic foods because it was rampant. And so we definitely see a lot of that. And sometimes it's just the pure OCD stuff where or just straightforward OCD where like I had a client who was afraid of antifreeze and getting contaminated with antifreeze. I had another client who was really, really worried about raccoon latrines in her backyard and her children's safety and mold. And then
mold
we see
is a big one right now.
a lot of overlap, with the eating stuff too and orthorexia. It's a great question.
Yeah, and there's so much like, well, what's the right milk to drink or the right oil to use, and what's the most appropriate supplements to have, and it really feeds on it. And that made me think of another one that I've been seeing a lot lately. This is not directly related to you, but like a new type I'm seeing a lot is this fear of inadvertently posting something to social media. and I have this fear of inadvertently, Alexia knows this, texting the wrong person.
Yes.
That's my thing. And I don't have
and now I have it because
Yes.
she told me about it. And so now we have to call each other all the time instead of texting because
but it is a thing that I'm actually doing exposures with people on of, you know, typing something into Facebook, or I mean, most of my clients, it's like TikTok, Snapchat, but and so really working on this fear of actually accidentally sharing something, like your phone did it without you knowing.
Right.
New stuff. All right.
Okay, so mute yourself. Oh, let's mute on this one.
Okay. Wait, and here's where here's how I said we have some problems with technology. We're having a hard time getting this video to go full screen, so
Right.
bear with us. We're just going to show it to you this way.
Okay.
Go ahead.
That's going to be because you have.
We got it, I think.
Computers on, yeah.
Yeah. Okay, so I'm gonna set this short clip up. So this is actually a documentary that was done by the BBC called Extreme OCD Camp. And it's actually the people who run it are two people that I know. One of them was my supervisor and mentor in Seattle. His name is Dr. Travis Osborne. And he and Pete Weiss run this camp for folks with OCD every year in the summer for about 4 or 5 days. And the BBC got wind of this and actually sent adolescents and young adults over from England to participate in this. I think they ended up doing a week-long program with them. So what we're doing now is they're sort of setting us up to meet the participants, and why we put it here is because you're going to learn about a bunch of different subtypes of OCD in this. Okay, so I'm going to play it and tell me if you can hear it. No. Can you guys hear that? No.
Yeah.
So how do I thought
We can do it on my computer.
oh yeah,
Okay. I'm going to pull it up here. So let me share.
Okay. Because if I unmute, then it becomes.
Okay. Hold, bear with us. This is what I mean. Okay. So actually, do you want to, oops.
For a second while the ads go through. We can skip the ad.
Can I full screen it? Okay, there we go. How do I get to?
Do you have to wait for this to?
Yeah. Bear with us, guys. Told you.
It worked perfectly when we practiced it a couple days ago.
Thumbs up if you guys
Jackie's
can hear
out
that.
shopping with his mum, buying essentials for his trip to the States.
We're good. Audio wise, we're good.
Can you see it?
Oh yeah.
Play bowls, play plates. Nice walk. No, that one's just got the black on it.
He's petrified of getting sick, so going anywhere without his own disposable plates
you
and
can't see
cutlery
it?
is unthinkable.
It's got lovely.
Okay.
All right.
Maybe unscreen, maybe unfull screen.
Someone, can you guys type in there what you can see currently?
We can see the slide.
Oh,
Okay.
hold on.
See the dice.
That's just my fault. Hold on. Ha ha ha. That was just a simple mistake. All right. Can you now see YouTube? Or
We do,
yes,
yes.
thank you guys. Okay, now I'm going to see if I can full screen it and it will work that way or not. Good.
Can you still see it? Now is it showing full screen?
Jack suffers from contamination OCD.
Okay.
No.
He sees germs lurking
All right,
everywhere.
we're just going to play it this way.
Okay. So just scroll back a tiny bit. 250.
Okay, here we go.
Jack is out shopping with his mum, buying essentials for his trip to the States.
I need toothbrush, toothpaste, soaps.
Oh yeah.
Play bowls, play plates. Nice book. Oh, that one's got the background.
He's petrified of getting sick, so going anywhere without his own disposable plates and cutlery is unthinkable.
It's got lovely.
Jack suffers from contamination OCD. He sees germs lurking everywhere. Even mealtimes are the most stressful part of Jack's day. He has to sterilize everything his food touches.
I can't touch the milk handle. So when my milk would say get poured inside a porridge, I'd have to have someone there to do it. You know, my mum who lives with me, she'll be the one that will pour that in. It's a 20-25 minute, half hour sometimes process before I've even eaten. It robs a little bit of dignity from me. The whole time I'm just sitting there thinking, you know, like, it's really pathetic. This is not how my life should be.
In an effort to turn his life around, Jack's committed to 10 days at an extreme OCD camp in the US. He and 5 other OCD sufferers are on their way to London to stay the night before flying to America tomorrow. Jack's the first to arrive at the hotel.
You're right. Lovely, thank you.
I could just get your address, signature here. I've got a pen here.
I got my own ones, honestly.
Okay.
Touching someone else's pen is not an option.
Do I have to sign this now? Can I come down and sign this once I've taken my bags up?
Yeah, that'd be fine.
Cheers.
22-year-old Josh is next to arrive.
How far have you come from?
We come from Blackpool, so quite far.
For the best part of 10 years, Josh has been plagued by symmetry OCD.
I have to touch everything with my left and right hands, my left and right feet, equal amount of times everywhere I go, 24/7. It's constant. It's touch that, touch that, touch that, touch that. You haven't touched it yet. Why haven't you touched it? It's constant. It's constantly there. I remember burning myself when I was 13 years old on my left hand on an oven at my nan's house. I felt compelled to burn my other 2 fingers on my right hand quite badly as well.
OCD has caused Josh to drop out of university and he can't get a job. He hopes that going to OCD camp will get his life back on track.
I'm hoping that when I go on the camp, it will improve my life, my social life, and hopefully it might help me to find someone.
Imogen is next to arrive at the hotel. At 17, she's the youngest member of the group.
I'm feeling nervous. I don't think it quite feels real yet, but maybe when I meet everyone, it'll be like, oh my God, it's actually happening.
A-level student Imogen is plagued by thoughts that terrible things will happen to her family. She believes the only way to stop these bad things happening is to constantly tap her surroundings.
It really does scare me, like the thought of, I don't know, like if you don't tap that tree, your mum's gonna die. You know, it's not logical because it's just a tree. But that fear is so strong that it just feels so real to me.
Next to check in is 21-year-old university student Olivia.
At the moment, I'm feeling about a 9 on the anxiety level because I really, really, really want a shower because I've been lugging these bags around London and I've been extremely warm and I'm very, very warm now in this hotel room. In fact, actually, I might have to
Like Jack, Olivia suffers from contamination OCD, but it's not germs that bother her, it's smells.
If you think of your biggest fear, some people's biggest fear of getting ill maybe, or dying, my biggest fear is anything that smells bad. When I'm showering, it feels like someone is, every time I feel like I'm clean, is throwing a bucket of mud on me. And then I have to start again.
Using the toilet is Olivia's biggest nightmare. So she's developed an extraordinary way of coping.
I would make sure I took photos of sort of the seat, maybe the lid in case my clothes touched it, the flusher, and the floor. Any kind of mark on the floor, I will take a photo of, and then afterwards, if I was still anxious about it, I could look at the photo and I could be reassured, or I could show someone the photo and they could reassure me that there's nothing wrong with that mark. I just like to be able to make my own judgments, make my own calls on things, and just go about day-to-day life without it controlling me, without controlling every move. Make sure I took photos.
Okay. So that just gives you a good idea, kind of showing you what we were talking about, showing some of those examples. I love that hers involves the picture taking, because that is something we see a lot, and that he has the symmetry one, which I think is less known. And so it's really, these are really good real life examples. I want to take these next two slides are really important, because like we've been mentioning that it's a sensitive topic to talk about here today with you guys. This is a very sensitive topic for clients. Many of them have been misdiagnosed, misunderstood, or judged when they share these with people before. So you need to be really, really mindful of your own reactions when you're discussing this, and mindful of your facial expressions and how you engage with them. And it's a weird balance of being reassuring and validating about how difficult it is, but also kind of non-reactive, kind of like, yeah, heard that one before kind of reaction. I literally have had clients who are misdiagnosed as delusional, or having psychotic type thought processes, or having some kind of sexual trauma that they don't remember having, by other therapists or sometimes psychiatrists, because that they're misinterpreted. And imagine going through life with this painful diagnosis or disorder already, and then you're misdiagnosed. So one of the things to think about is that some therapists are afraid to diagnose OCD when a client has some of these more sensitive topics, because the therapist is going, what if I'm saying it's OCD, but they're actually somebody that wants to harm somebody? And I will tell you, like, there are times you get really, really deep into somebody's thoughts and you go, God, am I missing something here? It can happen when you get really deep into it. Well, what if the person is really suicidal is a really big one, because there's a lot of focus on self-harm. What if I want to kill myself? And I remember sitting in a training once, and the trainer said that he literally brought a butcher knife in, gave it to a person who was afraid she might kill herself, and left her alone in the room with it. You have to be very, very brave and very, very confident in your diagnosis of OCD to do these types of exposures and make these diagnoses. Is the person psychotic? Sarah, I'm going to call you out because you direct messaged us, but she gave a really good example in direct message while I was talking about a client of hers that was afraid she had sexually abused somebody. And I really want to highlight, this is very common. Did I kill somebody? Did I chop them up into a bunch of pieces and put them into a trash can? And I don't remember doing it. That can sound really psychotic. That can sound delusional, but it's very classic OCD to have this sense of doubting reality and doubting your own memory of what happened and what you actually saw. Am I shutting down their healthy questioning of their sexual identity? This is one we have to be really, really careful of, right? What if they are unhappy in their marriage? I think that's the one that sucks me in the most, where people are going on, and I'm like, God, I don't know, maybe you don't love him, right? But really what it is about there is getting them to accept that uncertainty, right? So the thing here to remember, a really important thing to remember, is that the key diagnostic factor is that these people are distressed by their thoughts. They're not fantasizing about it, daydreaming about it, or having ideation and wanting to do these things. These thoughts are very stressful and they want them to go away. So somebody with suicidal obsessions is not thinking, I don't want to be alive. They're terrified that they might hurt themselves. And this is not like trip and fall. Like, they're terrified they may actually take pills or cut themselves, but they do not want to do that. Where it can get tricky is then what if this is so distressing that they become suicidal? I mean, this gets but remembering to focus on the fact that these are unwanted thoughts, unwanted urges that make the person feel scared, disgusting, shameful, and bad. It's also really important to not make your own assumptions about the client based on their OCD themes. OCD themes are pretty random. Sometimes a client will attribute it to something. They'll say, yeah, when I was a kid, and we do talk about core fears. What is your core fear? And is there kind of an early memory that's associated with it? So sometimes there will be like, when I was a kid, I did this thing, it was kind of gross, and now I'm afraid I'm a bad person, and my OCD has spiraled on that.
Right.
But the majority of the time, their themes have nothing to do with their actual personality, their life history, or their life values. So a really good example is that a client can have scrupulosity, OCD, and be terrified of going to hell and has maybe never stepped foot into a church in their entire life. And this gets its own little section down here. It is very important to remember, and you guys are not getting the slides on this because we had to cut this talk down, but that OCD is not caused by trauma. We have a whole bunch of slides about how OCD and trauma can overlap and what that's like and how to treat it. We're not going to do that today. So the takeaway is that trauma doesn't cause OCD. Can a traumatic event trigger OCD? Absolutely. But it is really important that if somebody is afraid of being attracted to an inappropriate person, or that they may have molested somebody, or I have had clients say, I'm afraid my dad molested me, doesn't mean that an actual trauma occurred. And it is really dangerous to fall into that trap of believing that because of the themes, there must be some forgotten or hidden or early trauma that occurred. Especially when the client is using words like, I feel gross, I feel shame, and I feel guilty. I have had clients say, I feel this guilt that I did something bad or that something happened to me. So it's really important to not fall into that, making that attribution.
Okay, and across cultures, OCD is, in terms of the prevalence, is pretty consistent across different parts of the world and across different cultures. And actually, OCD symptoms and subtypes are also fairly similar across cultures. What differs is sometimes the exact expression of OCD features, which could be, of course, influenced by someone's culture. So religion or superstitions that are specific to a particular culture or a particular community or group may express themselves in a person's symptoms of OCD. In assessing for these symptoms, you want to be careful not to overly pathologize what might be considered a normative cultural belief, right? So as an example, I'm Greek, and we really believe in something called the evil eye, which is this idea that someone could say something either with inadvertent intent, like jealous intent, or purposeful jealous intent, and will sort of jinx something positive about you, right? So an evil eye would be something like, your sweater is so beautiful today, Ashley, right? And to counter that, we actually do this thing where we sort of spit in the air. And so if I said that to you, you'd be like, oh, thank you, toop, 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 to sort of undo it. And that's just honestly, it's part of the culture. It's kind of fun. But it can go extreme. And the way you would know that is by finding somebody who is an expert or a specialist in that culture. And often it's family members who can kind of help tease that apart for you. I've actually called clergy and spiritual leaders before to ask them specific questions on behalf of my clients. But most of the time I will turn to the family members first. So I had a client who was a teenager, and he was East African, living in the Pacific Northwest with his mom. And his mother had very high standards of cleanliness that were cultural, but also specific to her family. So grandmother had the same kind of standards, but my client took it way extreme beyond what grandma and mom was doing. So mom would come home from work and change into house clothes. But my client would either never leave the house, or if he did and he would come back home, he would actually strip at the door and then go into the shower and shower for about 2 hours and then put on comfortable clothes for the house. And in those, the clothes for outside the house and inside the house were kept in separate locations. So you can see it's way beyond what even mom was doing. Let me just click on this. Oh, sorry. Okay.
So this one, and here's an example again of how this might work better in person, where you could just raise your hand and call it out. But I want you to just put this in the chat, and Alexia will monitor that. I'm going to read out just a made up case example, and I want you to just put in the chat what kind of themes of OCD you might be seeing. So her name is Sally, 17-year-old female, referred due to failing grades after a previous history of straight A's in high school. Sally was struggling to complete her homework because she could not start any activity, homework, mealtime, dressing, etc., until she had finished praying. She would pray for hours until she was sweating and dizzy. She believed if she started her homework before truly believing her prayer, she would go to hell and would no longer believe in God. Sally also had to ask her parents multiple times a day if they believed she was a good Christian or if they believed she was be able to go to heaven. Sally repeated many activities in her life, such as rewriting and rereading her homework, re-washing her hands, or re-brushing her teeth until it felt right. People really wear their enamel down. It's a thing. Sally had a history of tics in early childhood, and so currently was engaging in making weird noises or body movements whenever a thought of hell or the devil popped into her head. So go ahead and type a little bit, just right into that chat of what you guys are seeing. I can read them out.
Yeah, so we've got repeating and perfectionism, scrupulosity, just right OCD, scrupulosity, repeating, scrupulosity, just right, repeating. Yep.
I see one that people are missing is a lot of reassurance seeking and confessing. Yep. And that's kind of just the compulsive behavior, but absolutely.
Right,
yep. A lot of the repeating. Yes. And the other thing that's kind of a little, we didn't talk about it. She has a little bit of what we call Tourettic OCD too, where because she has a history of Tourette's, she's making a lot of these sounds and using the sounds as the compulsion to kind of get rid of those thoughts. You'll see people, an interesting one is like you have a bad thought and people will shake their head to literally shake the thought out of their head. Yep. So, now we're going to get into the treatment. Remember I said we get into the good stuff later on. Hopefully now we're moving into that. So we're going to walk you through the components. We're going to talk about how to do assessment. We're going to talk about psychoed, which is a really important part. I think a lot of people are like, well, psychoed is boring. It's really important here because OCD is misunderstood. We're going to talk about anxiety management skills, which is relaxation and coping. We are going to talk about how to make a hierarchy and how not to make it. And we're going to talk about how to just do ERP. And then we're going to go through case examples and talk about variations of treatment. And we're also going to address what if something goes wrong, because that is a fear that people have a lot as therapists. What if something bad happens when we do this? So starting with assessment, I'm just going to gloss over this pretty quickly, but definitely ask questions if you have them. The most important thing with assessment is to look for the components of OCD, the obsessions and the compulsions, but definitely looking for the connection between those two things. They have to go together. So looking to see that those compulsive behaviors are things that are linked to directly decreasing the sense of anxiety. So you'll listen for words like, I have to do that. I have to. They use those words all the time. And I will stop people and say, well, what would happen if you didn't do X, Y, or Z? Or what would happen if I came into your room and messed that up? And the answers are pretty telling. So it might be like, well, I would be mad at you for messing up my closet, but I just deal with it. Or no, we cannot do that. I have to keep my closet a certain way, or something bad will happen, or I can't handle it. Sometimes people are unable or unwilling to share the fears with you at first. Either they're shameful, feeling shame, and they don't want to share them, or they're not able to articulate them. And especially with kids, they just maybe can't articulate them. They just say, I have to. During assessment, this is okay. Especially with kids, it's definitely okay, as long as you can identify that the compulsions are performed as a function of decreasing the anxiety, the fear, the disgust, or the guilt. It's almost, I think of it like popping a pill. Like I take this, I do this, the feeling goes away. You also want to look at the severity of symptoms by measuring how much distress or how much impairment And we talked about that at the very beginning. So how much distress or how much time is it taking up? Rule out, and whoever had the question about autism, we are going to get to that, but rule out things that you want to be assessing for, such as delusional thinking, psychosis, autism, or just personality preferences. Okay, there are some people, not me, that just keep a clean house. It's not me. And one thing I want to say, I don't think we have this in the slides. We might. So if I'm going ahead of myself, I apologize. But I always think about a training I was at with Edna Foa, who's just an amazing presenter. If you ever get a chance to go to any of her talks, she said the difference between psychosis and OCD is that a person with OCD will usually almost always say, I know this sounds crazy, but I have to do it. So I know it sounds crazy if I don't swallow 3 times that my mother will die, but I'm not willing to take the chance because I love my mom. So I'm just not going to. I know it sounds crazy, but I'm going to do it. Somebody with delusional thinking will be convinced that they are keeping their mom alive, 100% convinced they are keeping their mom alive by doing these magical thinking type behaviors. I will say that the longer people have had OCD, the older they are and the more years they've had it, the harder it is to differentiate reality and OCD. It gets very twisted and sometimes can sound a little delusional.
And if you remember from the video, Imogen said that, right? The 17-year-old, she said, I know it's just a tree. And there's probably, there isn't really any way for that to be related to my mom dying. But OCD, if you remember from the beginning, lives in the what ifs of your mind. So it will say, yeah, but what if? Why would you take that chance, right? And so Imogen is saying to herself, what a horrible person I am if all I would have to do is touch this tree to know my mom for certain will be safe. And I'm not doing it. I'm choosing not to do that. It must mean I'm going to be a horrible person, which is why she couldn't bring herself to do that until you force her to treatment. Or me.
The example I always give is how many of you, like raise your hands in the chat or comment in the chat, how many of you would be willing to say, I hope my mom dies today? Every single time I say that as an example, I get this like hit in my chest. It feels awful to say, I hope my mom dies today. But I know it's not going to cause her to die that I said that.
Right.
But it feels awful.
It feels bad to feel like you're saying that or putting that out there.
Right. So if I could just do something to make sure she's safe, like not say it or tap the table 3 times, it's an easy trap to fall into. Okay. Real quickly about measures. There's different measures out there. The better you get at assessing, the less you're going to need the measures. But, depending on your preference, and we're going to talk about how we're different, you can use a standardized measure or an informal measure or just interview. The gold standard really is the Y box or the Psi box for children. And I do use this, and I'm going to let Alexia talk about it, but I use this a lot. Let me show you what it looks like. It is just basically a checklist of current and past when people have had different, this is the page of, this is like half the page of the obsessions. And then there's another page of compulsions. I use it as a semi-structured interview where I'm just writing all over this piece of paper to really, well, one, I'm assessing, but I also use it as psychoeducation and validation. So if I am saying to somebody, no, I don't have that page, but and have you ever been worried about being attracted to your family member, sexually attracted to your family member? It is extremely validating. This little piece of paper I'm holding has that written there because so many other people have that feeling as well. And so I use it to validate people, to kind of give them a sense that like, I know what's going on in your head. It's not going to shock me, to provide psychoeducation about these are normal types of OCD. And then from there, what I've written all over this paper bleeds into my treatment because I build my hierarchy off this piece of paper. So, but you want to talk about how you do that a little differently?
I don't always use the Y box because I forget. And it's just a true story. And I also was trained on the SCID. And so I have a lot of just kind of banked questions from the SCID, which is another semi-structured clinical interview. So I typically will do that. Interestingly, since the last time you and I gave this talk, I've been using this a lot more because I was so impressed by the fact that you use it so much. So I have used it a few more times, but it's not always the way that I do it. And sometimes I'll do it in the middle of treatment if I wasn't sure about someone's OCD symptoms, and I kind of come back to it. So it's kind of
I do
nice
that
to,
too.
yeah, to kind of come back and say, here's a whole comprehensive list if I'm missing anything.
Yep. And I will say it's like 7 pages. I only use 2 pages of it. So there are pages including how many hours a day, how much distress. People just get bogged down in that and they're like, I don't know. I really just use these 2 pages as I think of like taking the client's blood pressure. And then I will pull it out sometimes later in treatment and go, let's look at it again and see where you're at. And I'm not, even though I'm a very evidence-based person, it's only with this measure, and also I also use this with PTSD, where I'm really using a lot of standardized measurements because again, I forget. We're busy. So yeah. All right. So now we're going to talk about psychoed.
Yes. So I always begin with instilling hope, some motivation and cheerleading. And then I do share some etiology with folks. It really depends. The level of psychoeducation, especially around etiology that I give, really depends on the particular client. So with teenagers, I'm going to give less because they're going to get bored really quickly. I don't work with younger kids, so I don't really know what you would do, but you can speak to that. And then a lot of times, you know, I describe very briefly a little bit maybe between habituation and an inhibitory learning theory. I don't always do that. But I bring up a lot of psychoed in the beginning, so session 1 and 2, but then I'm constantly bringing things in throughout, right? So for example, if I'm in a session, you know, and it's number 10 and the client's SUDS ratings are not going down, but up until that point they had been, I would say, you know, that actually doesn't matter a lot if your SUDS aren't coming down. I'm just using that as a tool to gauge what I'm doing in the treatment. But it's so interesting because we used to think it really mattered. Now we know it doesn't matter as much. And that might be how I bring in a little bit of information about inhibitory learning theory, for example. But I do try to explain the core component of uncertainty, some of that thought suppression stuff, and then how and why exposure and response prevention works.
And I would say one thing here too is that this is just a over time learning thing. I have found that it's really, I want people to know the words. I want them to know ERP, exposure, uncertainty, magical think. I want them to know the words because a lot of clients with OCD, well, first of all, they're super bright. Most people with OCD are very bright people, but go out into the community and teach other people you need an ERP therapist, and they become advocates for this. So I want them to have that language.
Yeah, absolutely. Yeah, I always describe what does the exposure part of ERP mean and what does the response prevention part mean. So in instilling hope, I usually say something like, there are a lot of people who have OCD. Apparently there are 6 million people in the US that have OCD. You're not alone. If the number of calls we get in the area is any indication, there are a lot of people suffering from this. In Central Oregon, I'm still surprised by how many calls and emails I get weekly from folks saying, I have a diagnosis of OCD, or I'm looking for someone who specializes in OCD. I will share some of the information about researchers around etiology and things like that, but I will specify we don't know the exact cause. But it's important for clients to also know we don't actually need to know the cause to treat it, and that we can treat it very, very successfully. I usually say something like about 70% of people will get better from their OCD using ERP. Some folks also get better using medications. Some folks need a combination of the two. But for most clients, right off the bat, I will start with ERP. If they're not on medication yet, I don't assume everybody needs to be, but I will say to them, we might decide at some point medication might be something we want to talk about. We'll talk about that at a later date. And they're kind of like, okay. And then I will talk sometimes about newer treatments. You know, the ERP is still the gold standard, but there are other things we can try if we need to. Sometimes I pull that one in a couple months in if a client is getting demoralized. If they're not feeling a huge benefit from what we're doing, I will try to motivate them again and instill more hope and say, you know, we've only tried one thing. There are a few other things that we can try here. And then Ashley and I talk a lot about how one of the reasons we love treating OCD is because it works really well. It's a treatment that works well, and it makes us feel really good about ourselves that we're doing something that actually works. And I will say that to clients too. I'll say, I love treating OCD because the treatment works super well and I like feeling good about myself.
I also say that. I mean, we don't in psychology, we just don't have those kind
Yes.
of efficacy rates. And so to be able to say 70% of people get better is really good. I mean, that is the same as if you look at the efficacy rates on medication, not in psychology, but just actual medication for symptoms. So yeah, I'm biased, self-serving. I like treating something where I can help people.
Yeah.
So, all right. This is really an important thing. And this is something that has come about later on in training, but I really want to talk about anxiety management strategies. So it is very common in just general CBT protocols, whatever it is, treating anxiety, treating depression, treating trauma, that there will be a call for focusing on psychoed coping skills, relaxation, and cognitive restructuring, and doing those to really bolster the client. This is where I wish I could see you guys, because when we did this workshop, I said, please raise your hand if you feel that you missed that week of graduate school where they taught you all the magical coping skills that magically work for everybody and are effective and everybody loves them. Because I think I missed that week in graduate school, especially working with children. I mean, 99.9% of kids hate deep breathing. They hate it. So interestingly enough, what research is showing is that maybe these things are not so needed, because when they look at just treating anxiety in general, and they compared the changes in the child's anxiety or the parent report of anxiety to waitlist, no significant changes happened until exposure sessions began. When they looked at that in OCD, same thing. The research shows that the active ingredient is the exposure, not whether the kid likes to do deep breathing or mindfulness. Mindfulness is great, by the way. I'm just saying that whatever coping skill you're trying to teach. So basically, research says that people start to feel better after we do exposure. Bottom line. So what does that mean? Let's see. Wait a minute here. Okay, yeah, I didn't talk about that. I'm gonna answer that what does that mean question in the next slide. I want to take a moment and just talk about relaxation in general, and to really correct a misconception about exposure therapy in general. And I hear it a lot from clients. I hear it a lot from other therapists, that therapists believe that when we're doing exposure, we should also be using relaxation techniques to help the person stay calm, to help them get through the exposure. So and people will say, they will define it as exposure is gradually exposing the person while doing calm relaxation techniques at the same time. This is actually systematic desensitization. It is not the same. It's using counter conditioning. So it's pairing something scary with something calming, right? So does it work? Yeah, it will work, but it will work much more slowly. And if you never actually activate the fear response, if you never actually peel away the relaxation and the calming and all of the pleasant things and reassurances that you're providing, the person is never going to be able to relearn, like we talked about in the beginning, that they can tolerate it, because that isn't very real world. So the takeaway is that we don't typically use relaxation during exposure. The only time we would do that is if the person's anxiety is so high that the only way they can start exposure is by literally having you sit there and say, take a deep breath, you're safe, you're okay, and use some grounding skills as you're doing the exposure, and then slowly peel that back. Okay. So if we're not doing relaxation during exposure, if the research says these things are not as effective as we would hope, what do we do? Well, research doesn't yet say we should skip it entirely. They haven't compared that, but my clinical intuition says we shouldn't skip them entirely because of rapport. What we're asking people to do with ERP is very scary and very hard, and it is literally the opposite of what they've been training themselves to do for years. So we need rapport, we need trust, and we need commitment. So helping people have some active coping skills is going to give them a better sense of control, a better sense of commitment to the treatment, but hopefully also trust in you, even just through those general therapeutic rapport building during those sessions. However, what I do now versus what I did in graduate school is drastically different. I tend to spend maybe 1 or 2 sessions on this stuff, and then I dive into exposure therapy. How long I spend doing the build up stuff, the anxiety management type stuff, depends on how old the kid is, what their buy-in is, what their insight is, and how motivated they are, right? Just like you would in any kind of therapy before you get to the hard stuff, kind of like trauma work, right? But the takeaway is if you feel like I'm doing all these sessions, they're not that helpful, maybe you're right. Okay.
I think we should keep going a little
Okay,
longer. Okay, so this is an example of a self-monitoring form. So some of what we Ashley and I wanted to do in this talk was also just kind of talk about differences between us sometimes. So just to show that this treatment, yeah, it's an evidence-based, manualized to some extent treatment, but it's not rigid. It's very flexible. So for example, I really do very rarely any kind of coping skills with people before I start ERP. And I think that's because I just don't love it. And so I just want to skip it. But I also think because I work more with adults, maybe I think that could be a difference. I do spend more time maybe on psychoed. That helps me with the rapport building, and then I kind of go into it.
So basically, it's like the time before starting exposure is more important than what you're doing before starting exposure.
I think so.
Yeah,
I think so. And this is one of the things that I sometimes will do in the time before exposures. Honestly, I usually use this, not every time, but I usually use this if I don't feel like I have a really clear sense of what the client's symptoms are, or if they have so many symptoms that I find myself being overwhelmed when I'm asking about them, then I will assign this self-monitoring form. And it's pretty straightforward. I usually have them do one weekday and one weekend. So for a full day, but for a lot of clients, I say they're like, oh my gosh, it's constant. I'm going to be writing nonstop. And I'll be like, okay, just take a few hours then, just to kind of keep track for me. And the most important thing is I want to know, what are the triggers? What's the worry? What's the obsession? What's the thought? What's the urge or the image? And then what is their compulsion? Those are the things I'm looking for them to do at home. And then bring back to me. And then it kind of gives us a launching off point. Oops. Let's keep doing that every time. Okay. When developing a hierarchy, I can sometimes use the information from the self-monitoring form if I assigned it. If I didn't assign it, then I would just start kind of free flow asking them in the session to tell me a little bit about their obsessions and their compulsions. If clients have multiple symptoms or categories of OCD, which happens fairly often, I will often ask them which one they think they'd like to begin with. Or if they just say, I don't know, and they seem overwhelmed even by that question, I will try to begin with one that I think I might have the most success with. And usually that means one that is very easy to kind of behaviorally explain and write out, and that I think is going to involve some sort of active component, meaning if they're doing symmetry stuff, I might start with symmetry, but they also have a lot of obsessions about harm. I would probably start with the symmetry first because it's more tangible, and it might be easier for us to get some traction. So remember from inhibitory learning theory, one of the main takeaways that Ashley highlighted was more flexibility in the room and in the treatment itself. And this includes the hierarchy. So it used to be with the habituation model that you would start from the bottom and work your way up, and you wouldn't skip anything, and you would always make sure that their SUDS ratings went down before moving on to another item. We don't have to do that anymore. From inhibitory learning theory, we now know that actually jumping around some hierarchy items could be really helpful in strengthening the learning. We'll still make the hierarchies, and I will always start from the lower end because it's more tolerable to most clients. But then once I'm kind of halfway through, I might start jumping things, or I might start combining components of the hierarchy. And sometimes that looks like two different kinds of exposure, which I'll get to in a little bit, or it could just be the sort of different components of the same exposure. I just mentioned that. So using hierarchies more, typically I use them more with in vivo exposures than imaginal, but it can be used in both. And I'll describe in a second what both of those mean. You don't have to use them at all. You can, or in such a formal way. I have a tendency to write out in a lot of detail most of my hierarchies, honestly, because I'm pretty forgetful, and that's just kind of how I remember things better. But you can also just kind of pull up your whiteboard and start writing things down. I often will ask folks to just kind of walk me through what their compulsions or rituals look like, and I'll kind of write them down line by line. And then I will ask them to assign the subjective units of distress scale, or SUDS ratings, usually 0 to 10, just so that I can start to select a lower item as opposed to starting at their most feared symptom.
I used to overthink this. Don't overthink this.
Yeah. I always talk to clients about how developing the hierarchy is, and ERP in general, is very collaborative. So I tell them, okay, the reason we're writing all of this stuff down is so that we have a roadmap to look over, and that you will know what we're sort of targeting in treatment coming up, or what it's going to look like coming up. I'm never also going to force you to do anything. I will also say that to clients, that I don't have that kind of power. I'm not, if I did, I'd be the most powerful person in the world, but I will push you and I will challenge you when I think it's going to be helpful for you. But you just have to tell me that feels too much, and then we'll kind of backtrack a little bit. I explain to clients also that the ultimate goal is not for them to be in therapy with me forever. The ultimate goal is for them to become their own therapist and to basically adopt an exposure lifestyle into their life, so that they start recognizing these symptoms are, as new symptoms maybe come up in their life, I know how to treat this because I know how to do exposure generally. With kids, you would probably want parents to take on a little bit more of this role. Okay, should we do a few examples, and then
let's go quickly through a couple of them. We don't have to go through each one, and then we will take a break.
Okay. Yeah. So here's an example of one of my hierarchies. And you can see in this case, I didn't actually assign a SUDS rating to any of these. Instead, what I had her do, what I had her do is just walk me through this ritual or compulsions she has before bedtime for setting her alarms and checking all these things on her phone. So we just went through and wrote down every single component of this. And then the first thing I did was I started from the first item, and I'm just asking her for homework to start removing some of these components or messing with them a little bit. So her first homework assignment was, instead of turning on 6 alarms, to delete one of them. So now she has 5 alarms. And then step 2, I asked her, what do we do to mess up step 2? And she said, I could just eliminate that one. I think I can do that. And I said, okay, let's try it, and we'll see what happens. Then I also made her, we wrote an imaginal exposure script in the session, not pertaining to this, pertaining to one of her other symptoms. And that was another component of her homework. So then the next week when she comes in, I'm likely to delete another alarm, and then maybe try to mess up the next component on her list. Oops. Here we go. Here's a really detailed one. I had to go very slowly with this client. His anxiety was very, very high, but you can just take a quick peek at this. Here are SUDS ratings on these, because there were so many components to this. It was really hard for me to think of where I would start. And on the side, we came up with SUDS anchor points for him, because I was trying to get at really nuanced differences between a 6 and a 7, or 7 and an 8. Let me see. Here's something that we would probably do in the session with clients, right? I would have them, Ashley mentioned, like, stand up, and then I make them sit down, but they can't repeat it even if it didn't feel just right. But in the beginning, I'll allow them to seek reassurance from me. Okay, are you sure this means my mom's not going to die? Yes, twice. Then we start pulling that back. And eventually, by the end of the session, I'm hopefully having them stand up, not seeking reassurance, and not re-engaging in that movement.
And she just highlighted something important, that you can do multiple parts of this hierarchy in session, just based on, sometimes you can only do one thing. Sometimes you can do 4 things. It just depends on where the person is at.
Right. Yeah. Right. But we will spend 45, 55 minutes just doing exposure over and over and over again. That's the other thing that some people don't always recognize. Okay. And then here's an example of an imaginal script hierarchy, or some of her intrusive thoughts that I'm then going to turn into an imaginal script hierarchy. So fear about having sexual thought about animals, oral sex or inappropriate touching of animals. Here's some examples of contamination. This one's yours, I think.
This one's probably mine. Yeah. Contamination to me is like the easiest to design an exposure, a hierarchy about. So it involves touching worse and worse things over time, and decreasing how long or increasing how long they have to go before washing their hands. And you'll see that in each step, I'm adding the intensity level. So sometimes it might be touch something in the bathroom, wait to wash your hands. Sometimes it's touch something in the bathroom, spread all over your face and clothing, and spread it around and make it worse. And it goes all the way up to, and we're going to talk about this, touching the toilet seat and then touching your face, right? Without washing your hands afterwards. And people say, until when? And I'm like, until, sometimes I can say, until whenever you would wash your hands next.
Right.
Or sometimes with people, I have to say, how about 8 o'clock tonight? Right.
Right.
So, yeah.
And then
this example, while we were doing this talk last time, this is my low tech screen scan in, but this was a literal in session hierarchy that I did with probably a 7-year-old or something, where I just wrote down 5 things and then asked the kid, how scary would that be? And then they rated it. So it's really interesting because, so touch the back of the toilet was a 9 for that kid. Some people don't care about the back of the toilet because they rationalize that nobody touches that. So,
Right.
And this is a hierarchy.
Yeah.
And this with a little kid might take many sessions to get through. So, yep. So I think we'll take a break. There.
Yep.
Yep. All right.
10 minutes. But I think you
No. From Ray, where was that?
I found it. Do you incorporate Schwartz's brain lock model into how you treat OCD, or is his OCD treatment significantly different than you utilize?
So, Ray, I hope you're here, but I think, so this is interesting because we were talking about it in the break that neither one of us really uses this model that much, though we're familiar with it. But ironically, I talked to a client about it this week, which is really weird timing. And so I would say the answer, and so for everyone that doesn't know, there's 4 steps that are kind of cognitive steps about, and I'm not going to pull the 4 R's out of the top of my head, but it's like relabel, redirect, something like that. I can't remember what the R's all stand for, but basically it's like identify that you're having an OCD thought and redirect what you're doing. And it's kind of, in my mind, a little bit like cognitive and mindfulness together, but
sounds like the Puro Act stuff.
But what I added in when I was talking to my client this week, who is like, as I said, a lot of people with OCD are super bright. So she's like a great student and has read all these books, is I want to add in, where does the exposure happen in that model? So to me, it's label that you're having the thought, label your fear, decide to let that go and to move on, but acknowledging that your anxiety is going to spike, and that decision to accept the fear and move on from it and do something else and redirect yourself is the moment of exposure. And she gave me this, she sent me a TikTok meme of a person walking through a boat that's being like exploding around him, and it's a TikTok meme saying, me choosing to leave my compulsions alone or leave my obsessions alone.
Right.
So I think with this model, it's the exposure is the moment of choosing to label it and then let it go. And even she said, it's like your house is burning, but you ignore it. And that to me is the exposure. So I just add that piece in with clients and say, we need to identify that you feel anxious and that's okay. And the reason you feel anxious is because you're doing an exposure.
Yeah.
So that's my, it's not the best answer because I'm not that familiar with the book, but that would be my answer for you.
Yeah.
Thank you.
Yeah, and it actually does sound very similar to a recent book that came out by Carl Bajun, called Pure OCD, where it's from an ACT perspective, but he also gives steps. He and I can't remember what they are off the top of my head either. I did read this recently. But it was something along the lines of acknowledge that it's an OCD, acknowledge you're having the thought, label it as OCD, and then, various other components
and recommit, right? Recommit. Yes. So it's very ACT based, like recommit to your values.
Yeah. Okay. Another question we got was, when using the Y box, how do you differentiate between regular anxiety and OCD? It can be hard to do that, but I think one of the main components of trying to figure that out is, are they doing any kind of compulsions or rituals or something to neutralize their anxiety in a way that feels more like OCD than it would with general anxiety? I know that there are certain components of generalized anxiety that might look similar, but it tends to be very directly related to the thing. And sometimes in many cases, it's not directly related in a rational way, or a way that actually makes a lot of sense, right? So I would be focusing on the person's anxiety, but then what are they doing in response to the anxiety to try to tease that those two-
connection between the two versus just being overwhelmed by the worries. And I also think with GAD, it's like kind of sometimes flashing onto random things rather than I spend all day about this one thing.
Right.
That can be GAD too. But
right.
yeah.
Right. There's a question about etiology. Is it a result of a chemical imbalance? I think as with most questions pertaining to this, I mean, there's probably, yes, a component that is involved in that. We do see a lot of like MRI studies or fMRI studies that have this, that show the same pathways lighting up. Selective serotonin reuptake inhibitors work really, really well for OCD. So do some antipsychotics. So there are components of this that, of course, is probably related to some sort of chemical imbalance, but it wouldn't tell you the whole story. And actually, Jonathan Grayson does a really interesting thing in his book where he talks about how he almost makes a distinction between, like, I worked with a client and we did ERP and she did really great. And then she had a bunch of other stressors come up in her life. And it was almost like he saw that as a separate biological activation of her OCD, which he brought her back into treatment, did more ERP, and then recommended medication at that point. So I thought that was a little bit of an interesting distinction. Okay. The nighttime routine, did you see the person during the day and exposures and did their exposures at night? Right. Okay. So this is a question about one of the hierarchies with the alarm. Yes. So for a lot of clients, and this was an adult, actually not a child, but for a lot of clients, especially those who have really intense response prevention, or a lot of compulsions and rituals that you can't get at in the session, you can do telehealth sessions with them sometimes. If you think you can get at it in their home, you can actually go to their home to help with those things too, or do it outside of the session. But for things like at nighttime, yes, what I would do is I would come up with a really detailed explanation or understanding of their rituals, and then I would assign homework. And I have somebody right now who I have this issue with, and it's a teenager. And so mom is always in the room with us when we're doing this, when we're discussing his compulsions and assigning homework. And I also write it out for them, and I print it out and I hand it to mom. Because
you're better than me. I take a piece of paper and write it with a marker and hand it to them.
And so I hand it to mom, and then she can help keep him on track with his assigned homework.
Use parents. Parents are your
Yes.
co-therapists. It's a really strong pet peeve of mine if kids or even teens have been in therapy and the parents don't know what the kids are working on. Pet peeve of mine, because the parents should be involved because they're living it and they are a resource for you as a therapist. So
yeah. Do you want to do?
Sure. Day asked, on the list, like the hierarchy of the standing up one, is that an example of something in one session or over several? Yes. And yes, really, you move on from an item on the hierarchy when it no longer is invoking very much fear. So sometimes one item has to be repeated maybe in 4 different sessions. It's not that I'm saying they have to habituate, but it has to be, they're like, yeah, I don't like it, but okay. And you'll see it. You can just see it in the person that they're like, whatever. I don't do too much of repeating, especially things like contamination.
Right.
But when it's more about disgust or shame, a lot of times you have to repeat those a lot. Those are a lot harder than actually fear-based. So you just have to be creative. We have a whole side where we talk about therapist qualities, but you have to be creative, thinking on your feet about when you can move on. And then I really love Emily's question here of how do you address when the fear is realistic? For example, walking past an unknown person at night. And I like what she said is I generally talk about how the fear is warranted, but behaviors are unhelpful. So first of all, we never really have people do exposure to something that everyone would be afraid of, right? So, if it's something really dangerous or really that you should be afraid of, that's your body keeping you safe. And that's great, right? But what happens is a normal fear, like being alone, walking at night, then generalizes into tons of behaviors. Like, so I don't go at 4:15 because it might start getting dark, or I just don't go outside at all, or I check, or I talk to people on the phone when I'm driving at night because what if my car breaks down, or, and this spirals, right? So that's kind of an interesting example. That could be a GAD fear, but it could turn into OCD where it starts to spiral into all these other compulsions. So yeah, so I think focusing on what is, and there's no normal, but kind of thinking about what's functional and what would most people feel in that moment. We do have a slide on overlearning, and we'll get into that, where we do some things that most people wouldn't do, and we'll talk about that too.
Right. And I remember having a discussion with two of my male colleagues who were talking about, I think, a teenager or a young adult that they were working with in an intensive program. So they were both therapists of hers at the time. And they were saying about her sort of safety concerns around walking around and things like that. And honestly, I kind of had to call them out on it and be like, but you're a man, right? And so your level of fear doing some of the things, they kind of interpreted as she was going too far. And in my mind, the things they were describing were very normative to being a woman and walking around alone, or going from the office building to your parking, parking lot or whatever in a dark space. So I think that comes back to a little bit of the community that she belonged to versus that they did not belong to, and normalizing that.
There's an excellent Facebook group. I know this is a weird thing to recommend, but you guys,
true,
if you're, I don't know, put in the chat if anyone belongs to this Facebook group. I can find it and share the details later, but a Facebook group for people treating OCD. And it's like the best group that I belong to in terms of consultation and resources. But very, very common that people will post a poll and say things like, how many times do you wipe your butt after you go poop? And everyone responds because they're trying to get a sense of what is normal.
Yeah.
Or how often do you wash your sheets? And the answers are hilarious.
Yeah.
People are like, I don't know, once a month. And so it's really great to see. And they're just trying to get this information and feedback to their clients. So it's fun.
Okay, we'll pause on the rest of the questions for now, if there are any more, and we'll move on. So this is another wonderful quote by Jonathan Grayson. I very much like him, as you can, if you haven't been able to tell that by now, but it comes again from his book, Freedom from OCD. And he says, bravery is not a feeling. Bravery is how you behave when you are scared. You are among the bravest people I know. I just love that he says that. I think it's always so moving to me. Okay, so how and why exposure therapy works. So maximizing exposure therapy, again, using this inhibitory learning theory. So the idea, again, is how do we maximize learning when we're doing exposure with our clients? First and foremost, you need to identify what the core fear is, and you need to be able to activate it using exposure. So coming back to the question, what does the client need to learn? You need to ask what they would expect to happen in this situation and then plan exposures accordingly. In OCD, right, which is a little different than, let's say, a specific phobia, right? In the case of a specific phobia, I would ask the client, what do you expect is going to happen? Actually, I did an exposure with a tarantula where my colleague kind of showed me how he was doing exposures with this tarantula we had in our office. And he said to me, what do you think is going to happen when you hold the tarantula? And I said, I think she's going to bite me. It's going to hurt really badly. And then I'm going to fling her up in the air and she's going to land somewhere and I'm going to kill the spider that belongs to our clinic. And he's like, okay, well, let's see what happens. In OCD, it's a little bit more complicated because you have to come back to that uncertainty. So it's not enough for the client to say, well, yes, if I pick up this pen that I think I'm going to have the urge to stab Ashley in the eye. Okay, let's see if that happens, because OCD will in the back of my mind say, yeah, but what if it didn't today? But maybe that's just because Ashley's watching me, or that's just because my therapist is here. OCD will always find the loophole. So sometimes what the client needs to learn is, I can tolerate my anxiety. I can tolerate the uncertainty of this situation or accept the risks involved, or I can tolerate the disgust. And it's often not enough for them to see what they fear, just like I said, because nothing is 100% certain. Okay, here's a great quote that I actually think Ashley wrote down during this awesome training talk.
I was just talking and I was writing her quotes down. She just drops pearls of wisdom as she talks off the cuff.
And so she said, in the end, what you teach them is to take chances. You can never convince them it won't happen. Okay, so ways that we want to maximize learning during exposure is creating new learning between creating some sort of expectancy violation. So there's got to be a discrepancy between what the person thinks is going to happen and what actually happens. And again, in exposures for OCD, sometimes this means I can tolerate this longer than I think I can. The anxiety is more intense than I think it's going to be, but I can still handle that, or they can handle a worse exposure, or just repeatedly doing the same thing again and again in a way that doesn't make them doesn't make them feel safe.
It proves if you do it this many times, it's unlikely the bad thing will happen.
Right.
Yeah.
Right. So we also in ERP for OCD like to combine multiple fear cues. So it's really helpful to perform kind of different types of exposure at the same time. And I will talk about the different types of exposure in a second, and then maximizing variability in the context of the exposure. So, fear-based learning generalizes easily across multiple contexts. So if I see a snake out in the woods and I see a snake in my home, I'm going to be scared both times. And it makes sense from an evolutionary perspective. But inhibitory learning does not generalize as easily. So we need to perform the same exposures in multiple contexts. Yep. That means in the office, at a store, outside, in the parking lot, at their home, at grandma's house, in a variety of different settings and contexts. And we have done a lot of exposures outside of the office. We have done telehealth exposure sessions with clients where they're in their home and they're doing the things that they fear in their home. We've actually done in-home treatment for folks as well. Yep. For this reason. Yep. Okay, so what does it look like in practice? Well, we now have our hierarchy, and we would select an exposure target and have the client do it in session with you present, if you can. Sarah brought up a good point. There are some things that you can't do in session with clients. Then you just have to plan it out really, really clearly.
But do a lot of motivational interviewing.
Yes, while you're doing that. Yeah, exactly.
Make sure they're going to do it.
While they're doing the exposure in the session, we are looking for subtle compulsions or ways that they might be neutralizing, right? So an example of this might be like, okay, so I want someone to pick up this pen, and instead of picking it up like this, they pick it up like this, right? That's a subtle cheat. Yeah, it's a way to neutralize, right? Because what they're doing is they're probably thinking, well, this part of the pen is probably a part that less people have maybe touched, so I'm going to go for that one. So I'm watching for those things. I'm also asking them if they're telling themselves anything in their head, because if they pick up the pen and they're like, this isn't dangerous, this isn't dangerous, this isn't dangerous, I don't want them doing that. That's neutralizing the anxiety again. That's a compulsion. I actually want them to activate the fear and think maybe something bad could happen. Ashley and I also always do exposures with them. But sometimes you have to pull yourself out of the exposures if you become a safety. So for some clients, having the therapist do the exposures with them can be really reassuring. And I might do that initially, but then as they get better and better, and I want them, the exposures to be harder and harder, I'm going to say, okay, so you're going to do it on your own. I'm not going to do it anymore. Because I've had clients say to me, well, if Dr. Spouse is doing it, it can't be that dangerous. Mm-hmm. She wouldn't really put herself in danger. And I don't want them to get reassurance from that. Before we begin exposures, I usually say something like, okay, so I'm not going to ask you to do anything I'm not willing to do, right? Just to kind of put it out there. The problem is I'm willing to actually do quite a lot. So we're going to get going and we'll do a bunch of stuff together, and we'll just kind of see where you are. I will ask for SUDS levels or just some kind of feedback after a few repetitions. And I will point out to clients often that anticipatory anxiety, which is the anxiety you have before you actually start an exposure, is higher than during the actual exposure. As a perfect example, Ashley and I were both really nervous, well, maybe not really nervous. I was really nervous. She was nervous before the talk started. And I just remember knowing when her slide ended the first time and mine was going to begin, I swear I just felt this like sudden rush of anxiety in my body. And I was going, oh my gosh, oh my gosh, oh my gosh, in my head. Then I started. It's fine. It's fine. Now, I mean, probably within 10, 15 minutes, we were both way back down to where we usually are when we're giving presentations. So I know this to be true, Ashley knows this to be true, but anticipatory anxiety can be way worse than the actual anxiety during, and it's helpful to point that out to clients. We are always aiming for full response prevention because it's the most effective. So I want you to touch the contaminated thing, and I don't want you to wash your hands. Actually, in residential programs for contamination OCD, you're literally not allowed to touch water for the first 3 weeks or something like that. Like, no showers, no water. I mean, it's pretty intense, and it works really well.
And some parents have turned water off at their house. I have heard of that. Not my clients, but I have heard of that.
Yeah.
That's full response prevention.
That is full response prevention, but that's not always tolerable for people, especially in the beginning. So I'm not going to insist on that because they're not going to, clients won't come back. So instead, what we do is we gradually try to pull back on some of the response prevention. And you can do that by reducing the number of times they do a compulsion or the number of times they seek a reassurance, or you can work on increasing the time interval between their exposure and the compulsion, right? So if you remember Ashley's hierarchy with the contamination, she would say, touch the thing, spread it all over, and then you can wait 5 minutes before you can wash your hands or something like that. And then it'll become 10 minutes, and then it'll become 2 hours. How did I do that? I muted, sorry. While they're doing their exposure, I'm going to be asking them to describe their fear and the risk they just took. And in the beginning, I'm going to do this a little bit more mildly. So I'm going to say, okay, so what could have happened? Because remember, I'm trying to avoid them reassuring themselves in their head. So if I'm asking them questions out loud about the potential risks they just took, then I'm blocking some of that mental compulsions. So I might say, okay, so you picked up this pen. What do you think could happen? What could have been on the pen that you just touched? And they might say, well, like it could have E. coli on it, but that's not really likely. And I'll be like, well, how certain are you that you're safe, that it might not? It might, right? It could, right? And so I would ask them to do that. Then I'll ask them to repeat the exposure again. And then I might ask them to up the ante slightly and then repeat it again. We often talk about the spreading, right? So I touch the benefit of the spreading is because then you can't escape it, right? So I touch the pen, and then I might say, okay, so now touch your face, touch your hair all over, and then touch your body, touch your clothing. And without the escape option, they are submerged in their anxiety, which they need to be, and they'll sit with it and they'll tolerate it, and then they'll learn a lot more. The claw the spreading is a way to prevent the claw, but the claw is like, okay, so pick up the pen, right? Oh, good job, Alexia. You did such a good job holding that pen. Okay, now all of a sudden my client is doing this. They're just sitting in session and they're going like this. Their hand hasn't moved. Clients with OCD have an amazingly acute awareness of exactly where on their hand that pen touched. And so they're just going to do this and everything's rigid and they're not moving it. But I will say, okay, start by relaxing your hands, then spread to your hands together, and then we start spreading everywhere else. Try not to talk too much during exposures. This is a really big problem for some of us. I have a tendency to love to fill space with my chatter, but I will call it out for the client. Sometimes they feel uncomfortable too. It feels like it could be uncomfortable because it's silent, but I will say to them, okay, so you're going to do this, and now I'm going to be quiet on purpose because I don't want to distract you. I don't want to ask you other questions about other things. You're just going to sit with how you're feeling, and I'm going to check in with you every so often about how high your anxiety level is.
And I will say something that
Want me to cue this up?
Sure. What I do, and I do this especially with kids, but I literally do it with adults too, where I warn them ahead of time that sometimes I'm going to be mean Ashley, which means that I'm really going to use myself as a factor in that session to increase their fear. So I literally, like Alexia said, am drawing their attention to the fear, which might mean, oh, we have a chat. Can you hear me? Oh,
I don't know.
Yeah, we're good. It might mean me saying, okay, you didn't tap the table 4 times. That might mean that she could die. why would you take that chance? Are you really willing to take that chance? And I'm really going there and I'm really calling out the fear because you, the therapist, are part of the hierarchy. So that might mean that you are not saying very much in the beginning, or you're doing a little bit of reassuring in the beginning, all the way up to you challenging them and going, gosh, you really are willing to take that chance that that person you love could die. Why don't you just tap the table? And what's fun is people will start to argue back and they're like, I know it's not really going to happen. Da, da, da. And so it's just a thing that you might not think of as a therapist that you have to be able to do.
Okay, so we have some examples of what ERP will look like, and back to that video from the Extreme OCD Camp. And I want you all to just look at some of the strategies the therapist, in this case it's Pete, I think, uses, right? Both to kind of get out of the reassurance or some of the mental compulsions that are happening. Okay, so I have to turn that volume on.
Will force the Brits to fight their OCD by getting them to face their biggest fears and do things they'd never dream of doing back home.
Exposing to the fear, not doing the ritual, then we raise the bar and do it again, and raise the bar and do it again.
Straight after breakfast, the battle begins.
Sorry, we didn't share
in a
it.
place Jack.
Sorry, thank you.
This is so cool. We have like 6 tabs open on one computer right now, so thank you. We knew enough to keep the chat open because we knew these participants would help us.
Thanks, guys. Okay, here we go.
Is the most. The bathroom.
We're trying to find a spot, whether it's a wall or something on the wall, ceiling, that you can touch. Is there anywhere within the actual room where the toilet exists that you could actually do that?
Yeah, I mean, like, as far away from the toilet as possible.
Okay, let's just have you touch it with the pinky and then just kind of hold that pinky up for a while. How's that sound?
Yeah. I'm still taking my sleeves up though, because I don't want to get my...
Okay, yeah, you gotta be precautionary. Okay, it's there. What could be on your pinky?
Bacteria of the toilet seat and just what this room's about, and yeah, like water from the toilet flushed and just see.
So this is what we're gonna do, Jack. I don't always do this, but I think it's actually gonna help you. We're gonna have you touch your pinky around your body because I think it's actually gonna make it. It's gonna be harder at first, but then it will get easier faster. Get that bacteria, pee, urine, nastiness all over you.
My mouth went dry, my chest was beating, I was like sweating, my eyes were dying around the room, couldn't focus, like felt kind of like I was going to faint, although it may seem like a very kind of like simple task for everyone else. It was actually a big ordeal.
In Travis's group, Josh is first up. He's about to be
I want to skip ahead to Imogen because
that would cause you to want to tap.
Stepping for her family, but not let her tap to compensate. He'll ask her to rate her anxiety on a scale of 1 to 10.
What's the tiniest, most minute movement that would cause you to want to tap?
Stepping forward.
Okay, so what I want you to do is you're going to move your foot just the tiniest little bit. Go for it.
I know it's in my head. I know it's not real.
So I want you to say something different than that, though. This is going to be harder. Maybe it's real.
Maybe it's real.
Nice work. Nice work. That is fantastic.
Maybe it's real.
Okay, just stop there. What do you have?
Pretty bad, like a 5.
Yeah, a little higher than we wanted to, but we're just going to sit there. What do you want to do for a ritual?
I want to tap the wall with my elbow.
Yeah, I can tell that's hard.
When I moved my foot forward, I instantly was aware of all my surroundings, all these thoughts going around my head. Like I had really, really powerful thoughts about bad things happening to my mom, which was very, very scary.
Can you say it again? A maybe statement.
Maybe it's real.
Maybe it's real. Yeah, good work.
You did so well.
Yeah, that's so well.
This is unbelievable.
Yeah, I don't know how to give.
So you can see how he used himself in the session. At one point, she was reassuring herself and she said, "It's not real. It's not real." And he said, "Can you make it harder and say maybe it's real?" And then her anxiety really spiked. I don't know if you could see that she started to tear up a little. And he said, "Okay, stop right there." He kind of stopped her. And then he brought it back up again. And so he was using his words really carefully to kind of moderate her levels, which was nice.
Okay, here's the cursor. Okay. Okay, so different kinds of exposures. There's in vivo exposure, which is what we just witnessed. So direct exposure to feared situations in real life, right? In this case, it was the bathroom and the bathroom wall, and it was the actual movements that she does stepping forward. This includes feared objects, situations, people, or activities. Imaginal exposure are writings or recordings of obsessive thoughts, core fears, or feared situations using your imagination. And this is where we often will focus when we have a lot of obsessive thoughts, like harm thoughts. We will do some version of in vivo too. So I have a client with harm OCD thoughts, and he put away all the knives in his home because he's afraid he might hurt his fiance. So I had him pull out the knives, and gradually we've been moving the knives closer and closer to the bedroom. So they belong in the kitchen. He uses them now in the kitchen, but every night I have him move it a little bit closer to the bedroom. And then eventually I want him to just have it by his bedside table and sleep with it there. The imaginal exposure we're doing is me kind of helping him write out what are his fears, right? There's a chance that I might lose control and stab my fiance in her sleep. It's the kinds of thoughts that he's already having that we write down, and then I'm going to have him listen to them over and over again. Interoceptive exposures are not as common in OCD. They're exposures to the physical sensations of anxiety, but sometimes they can be really important, especially in situations like health anxiety or somatic OCD. And then the idea is to try to combine some of these together because you get more powerful learning when you do that. That's part of maximizing inhibitory learning. So that's basically what Pete was doing in this video. He was asking them to do a little bit of the imaginal exposure by saying what could be on the hand. If you noticed with the, I forget his name, the boy, he said, there could be feces, urine. He started to name some of the potential risks that he was encountering in the bathroom. And with Imogen, he was asking her to just say, maybe there's a chance that this could harm my mom. Okay, so just examples of in vivo exposures are objects, touching objects, using objects, being around or engaging with people. So I had a client who was an adolescent actually with pedophilia OCD, and I would have her go to playgrounds with children because she was avoiding doing that. I actually watch a lot of different videos. I think I just really like TV. And so I sort of bank these scenes and clips from movies and TV shows that I can use for exposure for my clients. Being in certain places that activate fear, like the playgrounds, eating things, saying things aloud, writing things down, touching objects unevenly. Imaginal exposures, the scripts can either focus on something bad that will happen or something bad that might happen. You just have to ask the client which one's going to be worse for them, and then start with the one that's a little bit easier and then work your way up. I tend to focus on scripts that are about things that might happen because I think that taps more into the uncertainty component that Jonathan Grayson is always talking about. So if they say it doesn't really matter, then I'll focus on the maybe one. You start with lower level scripts that are not as detailed, and then you work your way up to ones that are more detailed and harder for the clients. And some of them can get very graphic and upsetting. So I'm just warning everybody, I'm gonna read to you 2 examples of lower level and higher level scripts. These come directly out of Jonathan Grayson's book, but they have disturbing content in them. So if you want to skip out on this piece, just mute us or leave the room for a few minutes and then come back. And then you can include motivating statements, but not reassurance. So you're not going to say anything in the script about how this thing isn't going to happen or it's unlikely to happen, but you could say something like, I have to really work hard to get past my OCD. Yes. I want to work really hard to do these exposures, even though they're hard, and listen to these scripts because I want to get over my OCD, or I want to fight my OCD. But you're not going to say anything in there about how unlikely it is for these things to happen.
Yeah, you finish this and then we'll do that.
Oh, sorry. Okay. And then interoceptive exposures, again, it's just focusing on the physical sensations of anxiety. So hyper focusing on breathing in the session, spinning in a chair, listening to your own heart with a stethoscope. Or I even have a client now who will just by putting her hand here and feeling her pulse gets really emotionally kind of overwhelmed and very, very anxious by that. Lowering your head and then lifting it up quickly to induce the sensation of sort of dizziness or lightheadedness. Breathing through a straw, which I did with my client the other day, by the way. I was telling her I was doing this exposure with a client, and I mentioned I wasn't doing it with the client, and she's like, "Oh, really? I always do that with my clients." These straws? So I bought the regular ones and I have her do exercise and then breathe through the big ones, but I just bought these and they're coming next.
These are terrifying, guys. If you haven't done this, breathing through a coffee straw for a minute will invoke anxiety in almost anybody.
Yeah.
I've been doing it for years and I still hate it.
Right. Yeah. Staring into a mirror to try to induce the sensation of sort of derealization. Overheating someone, so asking them to bring a bunch of coats and then turning the heat up in the room. I've had clients where I have them lay down with blankets to overheat, and then I put books on their chest to get the sensation of it's hard to kind of move your chest or breathe up and down.
Okay, this is where I want to jump.
Okay.
I just wanted to address a question that's really related. Somebody asked while Alexia was talking about exposure, how would this look with pure O, just mental rumination? And I know we're supposed to leave questions, but this seemed Alexia started addressing that with imaginal exposure. Sometimes it is literally just getting the scripts into what the fear is. Like we see a lot of pure O, like obsessing over, do I love my spouse kind of thing. So a script about cheating on your partner and how you enjoyed it and how you really hate them and you hope that they suffer, that kind of imaginal exposure, getting into that core fear that you really are this person that doesn't love your partner, or that you're in a loveless marriage you're going to be stuck in the rest of your life and it's miserable. So we do a lot of imaginal exposures with that because that's where all the compulsions and obsessions are happening. But it also gets a little bit into Ray's question, and it gets into kind of almost act-based stuff of accepting the fear and then not ruminating. And it is, I will just be blunt, the hardest to treat. The best person who's doing the work on this in my mind right now is Dr. Michael Greenberg. He's doing a lot of work on mental rumination and how to stop it and almost how to turn it into exposure by labeling the fear, feeling the fear, accepting it, and then setting a timer and thinking about the fear for a few minutes, like imaginal exposure, getting yourself activated, and then just stopping and leaving it alone. So I will just be honest that is the hardest type of exposure when it's purely mental. But that's a little bit what it looks like. I just kind of wanted to bring that up because it fits right there. Yeah. Okay. So now Alexia is going to, this is a trigger warning if you need to.
You need to not be this for you. That would be helpful. Thanks. Okay. So this is a lower level script. This is one you would make in the beginning of treatment. I see my son riding his bicycle and the thoughts pop into my mind. I have to let them stay there without reassuring myself. I'll hate myself if anything happens, but that's the risk I'll have to take. I can't tell if I'm feeling anything, but it doesn't matter. If the feelings mean I'm aroused by him, then I'll just have to live being the kind of person that I am. I'm going to work at getting used to these feelings so at least OCD won't interfere with our relationship. I have so much to lose if I don't overcome my OCD. Okay, so the next one is it's a higher level one. It's more specific and graphic. What if I were giving my son a bath and suddenly was overwhelmed by sexual feelings? Suppose this happened just when I was getting ready to wash his penis. If this happened, just the idea of soaping it up would excite me. I might think that because he is 3, he won't know what I'm doing. But even though all of this might happen, I still have to confront my OCD and give him baths. Even if this ends with me blowing raspberries on his belly and while he's laughing, work my way down to his penis and then take it into my mouth. The sexual arousal running through me might be so overwhelming that all of this could happen. But he and I are going to have to take the risk that I'm really this kind of evil person. I'm already evil enough to have these kinds of thoughts, and I have to learn to live with this so I can be present with my son and be the kind of mother I want to be without OCD controlling me. So you can see the content here is really extreme and very, very difficult for a client to be listening to. But this is kind of what she's thinking about in her mind already. So, you know, we debated the first time we did this talk whether or not we were going to include this. And I actually think it's helpful. It was important enough to do because you might have to go to this level of a script for a client in order for them to get better, because this is the kind of thoughts that are going around in their head anyway.
And I hate it.
Yeah.
I mean, I'll just say every time she reads it, I'm a mom. It makes me feel, oh, right. It is just really hard. And that's okay. It's okay to say to the client, yeah, this makes me uncomfortable too.
Yeah.
Let's do it. And it reminds me of when you said it reminds me of trauma work. When people say, why would you make me relive my trauma? It's because you are living with these thoughts day in and day out. So we need to share that burden and we need to go there with the client. And I don't know about you, Alexia, but I think when we make them really extreme, sometimes is when the person will say, but I don't really want to do that.
Yeah.
And they go, no. And it's like, so when you take it to the extreme and you say it out loud is when it's sort of gut punches them too, but that's not really truly me.
Right.
Which is what you hope will actually happen through exposure.
Right.
So,
right.
yeah.
It's okay. Okay.
Okay, so speaking of things that are taboo, speaking of things that are uncomfortable, here's an uncomfortable slide. We're going to talk about overlearning and what overlearning is and why do we do it. And so these pictures here of, somebody touching a toilet seat or the word murder, or the most graphic one of the knife to the arm, which is something that people really do in exposures, are examples of overlearning. They are not things that we generally do in day-to-day life, like just go touch a public toilet seat. That's not something people normally do. So what is overlearning? Why is it important? I mean, I'm kind of twisted now. I've gotten to the point sometimes where this is the most fun sessions where we do this. So overlearning exposure tasks are extreme tasks. They are things that we would not do in normal day-to-day life. And I tell the people that I'm like, yeah, nobody does this in normal life except maybe us, but this is not what you do regularly in life. But we do this to prevent backsliding. So let's say we get the person comfortable with not doing their compulsions of, tapping the floor so their mother doesn't die, and we leave it there. That person might backslide. So what we want to do is make it more extreme, where the person says, I hope my mother dies, right? We do that because in life, there are things that happen accidentally. So I'm jumping around a little. An example we give to people is like a sports analogy. So people, I'm not really an athlete, but people who are extreme athletes, they overtrain for something. So when they end up in a competition, then that competition feels easier. Weird fact about myself is that I guess I am an athlete. I ride horses. I ride dressage. It's a level-based system. You are supposed to compete at one level below what you are training at so that you feel prepared. So part of why we do this is to get people to feel prepared for when a worse fear pops up. We also want people to be prepared that accidents can happen. So if you're afraid of contamination fear, maybe you're using a public restroom, maybe you accidentally drop your cell phone and it touches the toilet seat. Maybe your hand brushes the toilet seat. We want the person to feel strong so that they can say, that's okay. Remember that time in therapy, I put my hand flat on the toilet seat. I can handle this. Or if those little fears start to creep back in of like, am I a bad person? Do I want this to happen? If I do this, will something bad happen? They can go, that's okay. Remember that time in therapy, I asked for the bad thing to happen and nothing happened, right? These are typically the top of the hierarchy. So by the time you get here, the person is an exposure expert. They understand it. They don't think that it's crazy. They get it. They think it's crazy when you first mention it, when you first put it on the hierarchy. But by the time you get there, they're like, all right, bring it. Let's do this. They get it. For kids, that means we play games, we give prizes because they've just done something that most people can't do. Alexi and I always joke because we actually are totally separate businesses, but happen to share a waiting room. It's a fluke. That both of us have probably spent so much time in the public restroom in our office building, touching the toilet seat, touching the floor, just doing things that are weird and gross. And you have to be willing to go there. As the therapist, you have to be willing to do this too. I also include parents, and it's funny watching which parents are like, yeah, sure, okay. And other parents are like, no. And if I think the parent's going to have a ton of fear about it, I don't include them because we don't want them to model that fear. But this is fun. This is also hard. So we have an example, and it is the best example. I show this to clients all the time. It is well, I'll let him explain it, but it is an OCD therapist, and he is doing this exposure as part of a it's like the OCD Face Your Fears Week. And it's a dramatic example. I have never done this myself, of an overlearning. So again, please comment in the chat if we make a mistake, but I'm going to try to do this with no problems here. So
can you click it?
Yep. Okay.
I'm going to turn this sound off really quick.
Okay. Hold on. We're just going to get through the little ad. Then I will share it.
Skip.
Okay. Hold on. All right. Hold on, guys. We're going to do this more. We need to get better at this technology, huh? All right. Okay, here we go. Can everyone see that? Someone provide some reassurance in the chat.
Anxiety and Behavioral Services in Columbus, Ohio, and I'm doing exposure for OCD Awareness Week. And maybe because I'm a therapist, and I do a lot of exposures, there's not really a lot of things that I'm afraid of. And so I decided to do one of the hardest exposures I've ever done, which was thought up by Edna Foa, I think, who was one of the pioneers of exposure with response prevention. And man, I thought that I wasn't really that anxious about it because I've done it before. But I've avoided it all week. And it's not that I forgot about it, because I thought about it every single day, and it's Friday, and at the end of the day, and I'm doing it now. So what I'm going to do is a contamination exposure with a glazed donut, and I'm in a public restroom in the office building that our practice is in. And so, and I'm going to try to, one up the original exposure, which was to take a sticky glazed donut and then put it on the bathroom floor and kind of step on it with your shoe to kind of really grind it in and eat it. But I'm going to try to go one above that. So I'm going to put it on the floor and step on it with my shoe to really grind it in. And then I'm going to dunk it in the toilet and eat it. Ugh. And I didn't clean this toilet in advance. Okay. You know, it was kind of a dry donut. The toilet water kind of helps a little. Oh, why did I do it twice? Oh. This is real.
That is my favorite part, when he says, why did I do this twice?
We had the same thought.
Yeah, it's graphic, and yeah, fear factor. It is. I love your guys' answers. Thank you. And it's too funny because you could see that it's like a natural, like actual response where he goes, oh my God, I took another bite. And he's, yeah, I like to share this with people and then say, I promise I won't make you do that. So then what we do doesn't seem as dramatic. Well, but I have to say, remember the Facebook group that I mentioned? He shared this in the Facebook group, and he said that he has taken this off his professional YouTube because people were so horrified. So he didn't want to give the wrong impression without explanation, right? So yeah, it's just my favorite. I believe oh, what am I doing here? Oh, hold on. Okay. Are we back? No.
Keep clicking the picture.
I am
Dr.
hold
on, guys.
anxiety and behavioral services in Columbus, Ohio, and I'm doing exposure for.
My link is working too well. It keeps bringing my link back open. All right. Okay.
We can
And
save this one for the.
hold on. Now I need to reshare.
Oh.
I think. Where's my? Okay. Right here. Okay, what we're going to do with this next video is, like Alexia said, we're going to share this over the break just to save time. So if you guys want to watch it, you can. And it is an example of overlearning and doing something really gross. And we really wanted to share it, but we also want to be cognizant of time. So yeah. Okay, I'm going to do a couple more slides and then we will take a break. Okay, so this is what I want to talk about now, and this is related to overlearning, but it is also just related to doing exposures in general. And this is something that's really common. I've done supervision of people who are doing exposures, and this comes up a lot. So what if something bad happens? In fact, the last time we did this talk, we had a very well-respected member of the community here in Central Oregon who raised her hand and was like, yeah, this is my fear, and shared what she was afraid of. So if we engage them in exposure, what if they cry? What if they have a panic attack? What if they just walk out of session and never come back? Or worse, what if the feared outcome actually happens? And the answer is, it's okay. Remember that we are therapists. That is what we are. And so we might be doing a manualized treatment, but we are first and foremost therapists. So when a client is upset, stand with them in their fear. Be compassionate. If you have hit the mark too high and their anxiety is too high, always go back to psychological first aid. Use support, use grounding. It is okay to do reassurance if you need to bring their anxiety down in that moment. But remember that this is what we're trained to do, is help people with their difficult emotions. If you're a trauma therapist, you're comfortable with this, sitting with a really difficult emotion. If you feel that they're struggling, and this can happen where you think something's going to be easy, or the client thinks something's going to be easy and it is not, it is okay to hit pause. And you kind of saw that in the video where he said, hold on, don't do any more. And to really just step back. And so what we call it is stepping back, but not stepping down. Okay. So that might mean stepping back for the session. It might mean stepping back in the intensity of the exposure, but continuing to think about how we can turn this into a win. So I have stood with people and said, let's count to 10 and do it for 10 more seconds, right? But really often we are more afraid of the client's emotionality than the client themselves. And this is what we said about the imaginal exposures, is that the client is living with this. And so this is something they're living with day in, day out. What they're afraid of, that anticipatory anxiety, is usually worse than what it will actually be. And then finally, they need to feel that fear in order to really activate their amygdala and really face that core fear and really exhibit in that relearning pathway. So you need them to feel afraid. What if something bad actually happens? And I'm going to do this slide and leave you guys with this. First of all, they usually are afraid of things that are unlikely to happen. You don't have people come in and say, I'm really afraid of catching the common cold, because that happens all the time. But more likely it is, I'm afraid of catching rabies or leprosy. That is unlikely to happen, right? Or that if I don't tap the table, my mom will drop dead. Unlikely to happen. But if something bad does happen, we correct their expectations compared to what reality actually is, because the bad thing is usually not as bad as they expect. People with emetophobia, the fear of throwing up, best thing that can happen is that they get sick and throw up, because it is not as bad as you have built it up to be. Remember, it's important to acknowledge to client that the bad thing could happen. Oh, there's a typo. The bad thing could happen, but we're willing to take the chance. That intolerance of uncertainty is what keeps the OCD around. So we need the client to accept the possibility that the bad thing could happen. So you, as the therapist, also have to accept that too. Couple of case examples, real case examples. I had a client doing elaborate rituals every morning in order to prevent bad things from happening to her family. She would be late for school every day, or sometimes not make it to school. And we just slowly whittled this ritual down step by step by step until the last day where she did no ritual and just got up and went to school. And that day her very close family member caught COVID. And what she said was, I realized scientifically that makes no sense. So it was actually the best thing that could happen. Her father was fine, right? But for her to realize me doing that ritual really couldn't keep him safe from COVID. Another one is I had a client with a lot of fears about something bad happening to her dog, and a lot of checking behaviors around her dog's safety, hours and hours and hours of checking behaviors. One day, after decreasing those checking behaviors, she took her dog out for a walk, and the leash actually snapped in two. Like, what are the chances of a leash actually just snapping in two? Because one of her behaviors was to meticulously check every inch of that leash, right? And so the first day she didn't do it, it snapped. Dog ended up in a really bad fight with another dog, needed to go to the vet, get stitches. But what she realized was, I do all this work, and even though I've been checking this leash every day for 3 years, I can put so many hours into trying to keep my dog safe, and bad things can still happen. Maybe I shouldn't be working so damn hard to keep my dog safe, because it doesn't make that much difference. So sometimes the bad things actually are really good treatment moments.
And I'm going to do the next slide because this one relates,
okay.
and then we'll take a little break. So Jonathan Grayson actually has a response to this too, and he calls it the 3-house rule. And I'm not going to read all of this to you, but I'll just explain it pretty quickly, and I'll leave it up for you guys to read it, and then we can play some of the video during the break as well. But basically he's saying you can't guarantee that anything bad will not happen. And so you tell your clients about the 3-house rule. And he says, let's say you stop checking the stove as part of your OCD treatment, and because of that, your house burns down. He said, I would make you continue to do your exposures if that was the case. And he said, so we'll continue with exposures, and you continue to work on not checking your stove, and then a second home burns down. And he said, okay, so I would think you're really unlucky, but I would still make you do another I would still make you continue to do your exposures. Now then, let's say a third house breaks down while you're in treatment because you're not doing your compulsions. He said, after 3 separate houses burn down on 3 different occasions, then we might go back and reassess kind of what it is that you're doing, and we might change the treatment plan a little bit. But there are milder versions of this. I had a client where we would do contamination exposures in Pike Place Market, and we got sick with a cold. Every single week we would do this. And I made him do it 3 times in a row following this 3-house rule. And by the end of it, I had a suspicion there was one particular thing we were doing that was causing this. So we agreed we'll do all the other exposures. We won't do this one. We did all the other exposures. We didn't do this one, and we didn't get a cold the next week. So there is a milder version of this, but it's helpful for clients to hear this too. Okay. All right. Let's take a break.
We'll go on a break, and we'll play this video in the background, but go ahead and take your breaks. All right, so I'm going to start with Laura's because it looks like we maybe missed that one, and also because Alexia's grabbing some books. But she said, do you have suggestions of general OCD questions to use in the diagnostic interviews for patients not coming in specifically for OCD? I mean, I think I don't have like a set standard. I think like the more comfortable you get with just feeling it out.
Let's go polar bear. Polar bear button.
Can go there. But I mean, just things like, do you have things that you have to do in a certain way? Do you have repetitive things you do over and over? I like to use the word have to. Are there things, if you couldn't do them, you would feel really, really anxious or uncomfortable? Are there things you get stuck in? So just kind of feeling that. And then when I get that, then I go really deep into digging into, is it a preference versus a need? You know, is it or is it a coping skill versus a compulsion? Getting into the have to. I have to do it or the world will fall apart, kind of the connection between the two.
Yeah. I also ask about intrusive thoughts. So are there thoughts that pop into your head kind of out of nowhere that feel unwanted or inappropriate or upsetting in some way? And if they say yes, then I probe more because we all have them. But it's interesting because even though all of us have intrusive thoughts, people without OCD don't usually respond yes to that question, because they sort of recognize like, yeah, but it's not a big deal almost. They kind of distinguish it in their own mind. So they usually will be like, nah. And I'll give them examples, like thoughts about being contaminated or having germs, or fears of contracting an illness, thoughts of harming someone, even though you don't want to, urges or impulses, you know, like jumping in front of something, even though you don't really have a desire to do things like that. I'll just kind of give examples.
People
Yeah.
kind of know, I think sometimes. Yeah.
They know kind of what you're getting at most of the time.
And then there's a question about books, and I'm guilty of not recommending very much bibliotherapy just because I just don't think of it. But there are some clients that ask for it and want it, and Alexia says she does.
Yeah.
And ironically, in the break, I went to my bookshelf to grab books and realized they're all at home right now, all of my OCD books. But here we go.
No surprise, this is the one that I usually keep. I referenced it throughout. This is the one I usually will have clients read, and they, you know, I'll assign chapters to them, and I don't actually want them really to read chapters that are about OCD they don't have. They don't need to do that, but I also won't tell them not to. I'll just kind of say, like, I would just focus on read these 4 chapters, then come back to me, and then we'll talk about which next ones to read.
Wow. I'm impressed.
Yeah. But only with adults, and only with people who I think are going to actually read it. This one more recently that we just talked about.
And some of these are at the end in our slides.
Yes.
Not all, but some of these are in the slides at the end.
Yeah. This one, when it's pure OCD, and this is an ACT-based book, but it's relatively new, so it's probably not at the end. And then for family members whose relative is not interested in getting treatment, but they need help managing it, this is the book I would recommend. It's called Loving Someone.
She says we can't see the titles. What we'll do is type them in the next break. We'll type them into chat, or we could email them out. We'll get them to you. Yeah.
Okay. It might actually be at the end. Most of them.
Some of them are. Yeah. I also like in Alexia said there's an updated version which tells you how old I am, but Getting Over OCD, and it's called a 10-step workbook for taking back your life by Abramowitz. Oh, she has the updated version.
I do. Oh my gosh, look how different he looks.
Oh God, he has hair in mine and not in hers.
Anyway, yeah, this is the update.
And I also like for kids, if this is at home, but it's called Talking Back to OCD, and it's by John March, and that's a really good one. And then this one, I am not an expert in self-compassion. It's like on my to-do list to get more training in this. If any of you are, like, power to you. But Kimberly Quinlan just came out with this, and it's self-compassion for OCD. And I really like it, especially because I'm not as well trained in it. So I can say, why don't you read that book? And it really resonates with people that are really intellectual and critical of themselves. Okay. The COVID question. So the question is, if somebody is taking COVID precautions, what's reasonable versus excessive? And it's ironic because living through COVID as an OCD therapist was a weird time. A lot of contamination exposures just hit a screeching halt, and we just stopped doing them for a while. And then people just kind of started. There was no, but what they were doing at the time was trying to follow CDC guidelines and stick only to those. But yes, there are some people that will disagree with you. What is a good COVID precaution, or what is just general hygiene precautions? And they struggle with the over learning type things. And so sometimes you have to agree to disagree. And sometimes you have to say, well, this is something we disagree on. I think it would be beneficial to you to do this. But if you're not comfortable, I have done that with people with really, really either entrenched beliefs, or they have a very strong health reason to not expose themselves. And that's valid. That's like the question of walking down a dark alley. Like, I wouldn't ask someone to do that if somebody has a health reason that if they were to catch something that would be compromising to them, that's valid, right? So it's just kind of, but goes back to function. Like, how is it affecting their life and the quality of life? And is it over the top in terms of the function of it?
Yeah, we missed a couple of questions earlier, so I'm just going to go back to one of them. Is it okay to have the client speaking the exposure fear aloud? Yes, definitely. We often want that. That prevents them from doing mental rituals, and also it keeps them activated in their fear. I think we answered the question about pure O mental rumination. Yes. Okay. What do you do if the client is still feeling highly anxious at the end of the session is quickly approaching?
You get really good at feeling for that.
You try to end a little earlier so that you can kind of, maybe debrief a little or talk to them about their homework assignment, just kind of bring them back down. I try to avoid doing any kind of calming or relaxation exercise because we don't want that really. But if you feel like they're so highly activated that it's not a great idea to sort of send them out into the world in that state, then you would do that. You would kind of similar to prolonged exposure for trauma. You can do that, but you try to kind of leave enough time to say, okay, we're going to stop for now. Let's talk about the homework. Let's talk about your reactions. Let's see how you're feeling, and then kind of move on. Maybe even,
you get a feeling for it. And you get better and better at it, but it can still happen. I have watched people out this window walk to their car to see how they're doing. And they always say, as soon as I walked out, I felt a lot better, you know? Yeah. Do you want to answer the one about scripts? Because I think you do more imaginal scripts than I do, Alexia.
Yes. What's the one about scripts?
Could writing scripts ever become a part of the fear? So is it evidence or proof that reinforces the fear? It's a good question.
No, because because I think you would, you're really trying to focus in on is the maybe. It's the potential. It's the uncertainty. So you would say, there is a chance, I could be the kind of person who would, take God's name in vain and, end up living a life of blasphemy and then be shunned by my religious community and blah, blah, blah. But then in that script, you would also talk about, I know this is really difficult to think about and talk about, but this is what I have to do. This is the hard work of the OCD. So I think if you're focusing, and again, you don't always have to, but I tend to focusing on the uncertainty component, then you're not reinforcing that belief because it's more of a fear than it is a belief system.
That's a good answer. Yeah,
that makes sense.
Yeah, and it's and you also said, is this the point of exposure in your question?
Yes.
And yeah, it's the point of exposure.
Exactly right.
To expose yourself to that over and over to change your beliefs. So yeah. And
Exactly.
And like I said, I love it when somebody goes, but I would actually never do that. Like that's the best moment. Doesn't always happen, but and then the last question, really good question about self-harm. If somebody has an actual history of self-harm or suicidality, what do you do about those exposures? Well, obviously, as in any treatment, is safety and stability first. So you need to make sure that person is stable and safe before doing it. But usually, so yes, get them to a point where you're not worried about active suicidality. But usually, if there is a suicidal ideation, it's very different from the self-harm ideation. It's a different context. So I think there's a different feeling to it, and the person can tell you, this isn't something I really want to do. Like this isn't actually, they can articulate that. And then always seek supervision. I mean, I know that's a cop-out answer, but if you're worried about the person's safety, make sure that you are, because if you're walking a fine line like that, make sure you're getting supervision, because the last thing you would want to do is be recommending an intervention to somebody that's at risk. But again, there's a different feeling in my mind to those two types of ideation.
There's actually a podcast series called OCD Stories, and they did, there's like hundreds of episodes now, but they did one episode that I listened to that was about this. It was the sort of fear of suicidal ideation in an OCD client, and how do you kind of distinguish? And often a simple, maybe oversimplified question to ask is, how do you feel when you have this thought? Do you feel scared or anxious, or do you feel relieved?
Yes.
I asked that the other day of a client because I wasn't positive, and she said relieved, which means that was real suicidal ideation. It wasn't an OCD fear of hers. Yeah. So then I had to mobilize on that.
Yeah, because it goes back to that slide about focus on the distress that it causes, and that the person doesn't want that action.
Right, exactly.
Okay. So now we're going to move into like some case examples to look at exactly what does this look like in action. And I have one example and Alexia has another example, and we're going to walk through what it really looks like. Then we're going to talk a little bit about maybe any apprehensions that you guys might be having, and then we'll move into small groups. So here is, I chose this example for two reasons. One, I think a contamination is the easiest to conceptualize. So it's an easy one to understand the treatment, but also this person, she came in with such severe OCD. It was really an interesting case for me because the severity of the case all the way down to how much progress she made was amazing. So she had severe OCD surrounding rabies. I mentioned that before, like she's not the only client I've had that had the fear of rabies, but she had worked at a facility somewhere and an animal had been exposed. And from there, it just triggered this fear of contracting rabies, or worse than herself getting it, passing it on inadvertently. We can all think of that with COVID. We were like, for me, the worst fear was, what if I got somebody else sick with COVID, right? So her compulsions were obviously avoiding any type of exposures, like not going out in the woods with her animals, not being, or if she saw like a dead animal in the woods or something that looked weird, she would avoid that. But all the way down to not saying the word rabies, not thinking of it, tons of cleaning of herself and her pets when getting home, internet checking, Googling, reassurance seeking. When all it increased to anything gross or disgusting became off limits. When she came for treatment, she could no longer leave her house and had so many rituals that her spouse was caring for her in a lot of ways because she was no longer able to touch so many things in her home. The only thing she really could touch was things that her husband had touched. So it was intense. So what I took her through is the assessment and psychoeducation piece. And then I stopped and said, I think you need a higher level of care. It's the first thing that I said. When somebody cannot leave their home, it's not good. And I'm an outpatient, just myself, running this private practice once a week. And she said, can't do that. Can't leave my house. Can't afford it. Can't do it. And I said, okay, well, let's see. I said, I think this is the wrong dosage of treatment for you. But let's see. I'm willing to try it as long as we can keep you safe and stable. Made a referral for medication. She was willing to do that. So that's a bonus, because when it's this high, you want to use meds. Involving her husband, because that was the person doing all of this accommodation and support. And then we did the ERP. So here's a little bit, this is not her whole hierarchy, but an example. So writing the word rabies, saying the word rabies, and the anxiety was so high that just to say the word was sobbing on my couch. And most exposures are not like that. Most exposures don't have that much emotionality. They're a little bit anticlimactic, but this person, just to say the word, would be sobbing. Touching my hand after I touch something contaminated. So if this phone is dirty, I would touch it and then she would touch my hand. Bringing home items that were contaminated, touching things in the community, visiting dangerous places, touching things at home that are contaminated, and bringing things to office and touching her dogs with contaminated. So it was the biggest fear, her poor husband. The biggest fear was the dogs getting sick, not the husband. And connected to the exposures is the response prevention. So there's multiple, my hierarchy here isn't written like stepwise, but there's multiple ways to combine these. It's like a menu, right? So do something and then don't wash your hands. Do something and then don't shower. Like go to bed without showering after touching something gross. Take something contaminated and cross-contaminate everything in your house. Decrease the reassurance seeking. All of those things together. So a low-level exposure for her, I already shared, was something like me touching a pencil to the trash can and then asking her to touch the pencil, not the trash can, but the pencil. And sitting with that feeling of disgust. Important for her actually wasn't fear, it was disgust. And research shows that disgust is actually a lot harder to get over than fear, because it is harder to engage in expectancy violation of I might feel disgusting versus somebody might die, right? And so really asking her to feel those feelings and sit with them and learn that she can tolerate it. Not learn that you won't feel disgusted, but learn that you can tolerate feeling disgusted. And then the top level hierarchy, and some things stick in your mind, and this one does, was bringing her dogs in and having them touch contaminated items and not cleaning afterwards. And the level of emotionality in that session was, as therapists, we don't have sessions that are like a scene out of a movie very often. Therapy is generally pretty boring. This was like a scene out of a movie. It was pretty amazing. And interestingly, this person came back for therapy, I think 2 years later. COVID had happened in between her therapy for OCD, came back for an unrelated reason, and none of the OCD had reoccurred. And she was working a full-time job. So this one violated my expectations that I didn't think she would get to that point. So
Okay, so K is a non-binary adult with fears of people thinking they are perverse or accusing them of harming their children. Kay was the parent of 5 children and a language interpreter. They worked per diem, picking up work on a forum rather than steady employment. Long-standing history of OCD starting in childhood when they made a comment to a classmate about his mom and then feared this mother would be so upset about the comment, she would die by suicide and it would be the client's fault. Saw a therapist for 7 years before being willing to see someone specializing in ERP despite their therapist's urging. So the therapist asked them repeatedly, go and find someone who specializes in ERP, and they wouldn't do it. Feared that while working, they would be asked to interpret something sexual or body related, and then people would see their face turn red and believe this meant they were aroused or looked guilty and report them to CPS. They've begun avoiding taking jobs for medical interpreting and at colleges. They also feared harming their children in a way that would require reporting and sometimes would check themselves. Like, did I get the shampoo too close to her eyes yesterday? I should recreate that again today and see. Okay, so here's some examples of hierarchy items that we did together. So I would have this client, I would pull up a video. Initially, it was innocuous videos that had nothing to do with their fears. And I would ask them to actively interpret while the video was playing for me. Then I had them actively interpret the videos using medical information. So one of the categories that they feared was being asked to do some sort of medical interpreting, and that would require using signs that were related to body parts and things like that. But so I'd have them do medical videos. Then we would do videos about medical information that had to do with body parts. Then I had them interpret TED Talks on sex trafficking. So the content of things that they really, really feared. We also read articles about child abuse, and we wrote a script about someone accusing them of hurting their children, CPS being called, the police showing up at their home, everyone knowing what this person did, and being hauled away to jail. In terms of response prevention, this particular client was not allowed to seek reassurance from me about what their face looked like in session. So they would often, ask me, did I turn red? Did it look like I had a guilty look on my face? Mm-hmm. And we sort of pulled back on that. And eventually when they would ask me this question, I would just say, I don't know. It might have, I'm not sure. I'm not answering that question. I also would put into their mind, you might look guilty during these exposures. Gosh, it could be that you're interpreting these things for me and you might be looking guilty while you're doing it. That might also happen when you're doing this for a job outside of this room. I would also tell them things like people might think that they're perverse, and just having to live with that possibility. And then I allowed them to seek reassurance from their spouse a limited number of times and started decreasing this number. So I also brought this person's spouse into the office where we would talk about reassurance seeking at home and ways that their spouse can start pulling back on the reassurance seeking. Okay.
Okay. So now this is an example of something that just doesn't work as well virtually, because in our last workshop, we had people do some exposures. We're going to have you do a couple. If you have paper with you, if you have a pen next to you, I want you to just grab that. And I want everybody to just take a pen or paper or pencil, if you can, and just write in big letters the word murder. Now write the numbers 666, then devil, and then sex. I did mine in different order. Pardon? That should look like this. And just put in the chat if anybody had any hesitation to write those words. Did it feel weird to write those words? Are you wondering, what if somebody finds this piece of paper sitting in my office or sitting in my home? The things that are in my office tend to be very weird. But just to experience a little bit, was that uncomfortable for you? Another example, and you're welcome to do this if you, she showed her husband. That's good. Yeah.
Not weird, but
I'm gonna shut it. Yeah.
That's the best.
Uh-huh. Uh-huh. Yeah.
Oh, yeah.
I had one client really, really afraid of harm OCD. So we would write like confession letters, like I murdered a person and I left their body in the alley and da, 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 da. And I actually got triggered. Like, I don't think I should leave this in my office. Like, it just feels a little weird.
Yeah. When I have clients doing imaginal exposures, I have them recorded on their phone so they can listen to it later at home. But then I always sort of find myself asking, do other people have access to your phone? Do your kids know the password to your phone? Could they find this recording? I don't do it in that, rapid succession. So it sounds like I'm panicked, but I do check up on things like that. Like, just curious, your kids get into your phone. Could they get access to this? Let's think about that when you put it on your phone.
Yep. And then another one here, I don't think we need to do this today, but we handed these out to everybody, these little Hershey Kisses, and had people unwrap them and just set them on the floor. And everyone was willing to do that. Just take the Hershey Kiss, set it on the floor. And then we said, now pick it up and eat it. And I don't remember, but I feel like at least a quarter of the people in our training didn't do it. That was too much for them. So you can't see, but Alexia is rubbing it around on the floor right now.
Okay, but remember the other thing we did was we took our shoe.
Yeah, but what we did with the shoe. Okay, go ahead.
You have a shoe, you have a chocolate. Let's do it.
Well, what I remember doing with the shoe, go, you do yours. I'm going to do my exposure.
Okay, so I rubbed it all over the bottom of my shoe. And then the top a little bit, because that seems to have some stuff on it.
5-second rule.
I think, well, then I also rubbed it on yours, I'm pretty sure.
Okay.
And look, it came off.
She like left some chocolate marks in the bottom of my shoe.
And then we asked people to eat it, which I did.
So
but most people didn't.
Sarah's saying she wouldn't do that. What I remember differently, and this is great, you actually prepped for mine without knowing, is what I remember is reaching down and rubbing my hand on the bottom of my shoe while I was still wearing it, and then just licking it. The reason I remember that is because A, nobody would do it, but then a man in the front row goes, "Can you do that again?" So I said, "Sure." So how many people would do either one of those things? Put it in the chat. Nope.
Eat it after it's open? Yes.
Oh, yeah. Oh, it's open.
Yes.
She left chocolate marks on the bottom
open.
of the shoes.
Yeah, the whole thing was open.
And in graduate school class. Oh, that's really cool.
That's cool.
Really cool. Yeah. This is an example of overlearning, right? Would most people do this? No. Most for money. That was a good answer. Most people would probably drop something quickly, follow the 5-second rule and eat it, which is funny because it's a social convention.
Right.
But the reason I wanted to add on the licking the shoe, because it doesn't fit any social convention. It's also just socially weird to do what I just did.
Yeah.
What you did is really gross because you left chocolate on the shoe and then ate it. It's not normal, but it's an overdoing. And it is something we do with clients. I have done both of those things with clients. I have had picnics on the floor with clients. And infections
preventions. Yeah, I know. It is kind of tough because sometimes when we have physicians as clients or the parents of our clients are physicians, they have some reactions to some of this stuff.
I found that doctors are like, yeah, it builds your immune system. Like that is literally what I've had doctors tell me. And they say things like urine is sterile. Like I think most doctors are pretty chill about this. And when I worked in the hospital, we did have to go through infection control. And I remember the guy going, chill out, like soap's not all that important. He goes, you can just brush your germs off like this. It stood in my head. So yeah.
Kissing slug. I love it.
Okay. So let's talk a little bit. Let's transition to talk about your role in exposure. This is really important and it's really meaningful to me as somebody who did supervision on this. This can be really hard for people. This can be hard to do these exposures. This can be hard to challenge yourself. So first of all, let's talk about how is this different than a talk therapy session? And I use that term to incorporate anything where you're not doing an exposure. So things that you might find difficult is that you have to think on your feet a lot. You have to be very creative and you have to be able to adjust and design exposures in the moment because sometimes what you wrote on the hierarchy does not induce any anxiety and you have to pivot and figure out how to make it a better exposure in the moment. The more exposures you've done, the better you get at doing that without even really thinking about it. But I remember when I started, designing the exposures was terrifying.
Yes.
knowing when the client is cheating. So Alexia called this neutralizing. So when they're not facing the fear, you have to be really good at understanding what they're doing covertly. We've already mentioned that, but it literally could be counting inside their head to undo the exposure so that it doesn't count. Sometimes people just really use logic to stay away from the emotion, and they just kind of, this doesn't count because this and this and this, and these are the reasons. And so you need to help them figure out how to get to that emotionality and not protect themselves by using logic to kind of stay in that left brain thinking. Helping your client stay at the right level of intensity that's not too high or too low. The more I do this, the more I think I tell people, my job is not to do anything that's that shocking or that you've not heard of before or you've not even thought of before. My job is to help you find the right dosage. Right. Because a lot of people have tried exposure without knowing they're trying exposure, but they try something way too mild or way too hard. And our job is to help them find the right amount and keep it moving. Knowing when you've done enough, you should just stop, and that was good for the day. Sometimes that's 5 minutes. Sometimes that, not usually, but it can be. And then doing the exposure with your client can be hard for people, depending on what it is. But things that you might find that are easy is that you're in charge of the session. You know what the plan is. You have a plan. It's pretty organized. Mm-hmm. It's not like, I wonder what we're going to do today. Right. I mean, I personally dread those sessions. When a client comes in, I have no plan. It's not OCD. It's just general anxiety. And I go, God, what are we going to talk about today? Yeah. I dread those sessions. This is straightforward. I think the more I do this work, the more of a behavioral therapist I am. But I think that it is simple, but it is very complex because you are doing a behavior that is changing the way the person sees the world and sees themselves. And then that generalizes to the rest of their life. So you're doing something very straightforward, like licking the bottom of a shoe, that is teaching them that they're resilient and that they can face their fears. And that's a big deal. It's goal focused, it's active. You have one clear goal for the session. You get to see immediate reactions and results, like immediate. People feel relief immediately and will follow up with emails sometimes, like, I already feel better. We don't get that in therapy that often. And then finally, you don't actually have to say that much. So you don't have to lead the session that much in terms of saying interesting and important things because you're leading it behaviorally. What makes a good ERP therapist? And kind of the reason we put this in here is, I don't know. I think this is probably my own defensiveness, but I think sometimes when you're an evidence-based therapist and you follow manualized treatment, you are worried that other therapists might have judgments of you. Like you are fairly concrete. That might be true, but that you are just following a textbook and you're reading it and you're emotionless and you are working through this session and there's really no rapport or flexibility or adjustment for your client. I disagree. I think you have to be extremely creative and extremely flexible, extremely quick thinking. You also have to be very calm because they're not going to be calm. So you are holding the emotional tone of the session, and there is an emotional tone. It is not just reading out of a textbook. You have to be empathetic, really genuinely empathetic. It might be something so small as the person touching the corner of your desk or not touching their nose. And you have to say, I know this is really, really, really scary, and mean it. You have to be enthusiastic. You have to be their cheerleader. You have to be brave. You have to do it too. You have to be self-aware of your own biases. You have to be confident. And most importantly, you have to be non-judgmental.
So I want to point something out here. So if you remember from the two videos, Travis and Pete were both really enthusiastic, but in not in sort of pedantic kind of condescending ways. Yeah. Like Pete, when Imogen said a few times, maybe it will happen, or maybe it could have come true. The third or fourth time she said it, he goes very genuinely. He sort of said like, oh, good job. That was really good. Right. It was a very genuine response. And then Travis, after, and I forget her name, went to the outdoor toilet, came back to the whole group to celebrate her. And again, it wasn't like, it wasn't patronizing in any way. It was like she just did the single hardest exposure she has ever done in her whole life, and everybody got to support her around that.
Yeah.
The self-aware thing is also really important. I don't treat airplane phobia. I'm just, I can't. I've worked on it on my own, and I've read the books I have to read, and I've done my own sort of version of exposure. I just can't do that because I couldn't get on a small plane with a client, which is really probably what you would need to do at some point with your client. So I'm aware of that. And so if a client reaches out to me and says, I'm really afraid of flying, I'm going to refer them to Ashley.
Great.
Yeah.
But I mean, but you know, you also have to know your own family history, your own life history. So if you were exposed to something traumatic in one of these categories, you may not do this work, right? You know, or you may not do that type of subtype. Okay. So we originally had this set up as small group, but just because of time, we have another small group activity coming up. I would rather, I mean, I don't know how you feel about that.
I think that's great.
Okay. Yeah. Would rather just have you guys put some of this in the chat, but even have a couple of you raise your hand and answer this on video if you're brave, to discuss what hesitations or concerns or fears hold you back from doing this kind of work, or might be hard for you in this kind of work. Or if you do ERP, what are the traits that make it easier for you or hard for you? And then are there certain subtypes that might be hard for you because that exposure would trigger you in some way? So if we could get some people to put it in the chat, but also a couple people maybe to just speak up a little, raise your hand, and we will call on you. So you can raise your hand through the little emoji, or you can even just unmute yourself if you'd like, if no one's speaking up. Overdiagnosing OCD, doing it wrong. Yes. Yes.
Anything specifically?
If you do it wrong, you can always say that you're doing it wrong. We need to adjust. Move slowly. Yeah. Yeah. And I think that is really, really common, that people are taking their time. And I just feel like the longer I've done it, the quicker I go.
Yeah.
Working with kids and parents. Yeah. If the parents have their own OCD, I try to not include them as much, honestly. Not providing reassurance. We provide reassurance in everything else we do.
Yeah.
Yes, if with medical problems, it may be counterintuitive, but it's just like treating panic attacks where you would want to talk to the doctor and get that right after the doctor of what they could do or not do.
The resisting reassurance, a couple of people put that in there. And I think the way around that is to come up with some initially just kind of, standard phrases that you use that are not reassuring, but are supportive.
Yeah.
Like, not like everything's okay, things are going well, but things like, you're doing great. That was a really hard exposure.
Yeah.
Good for you.
I say I'm proud of you, like, and not in a fake way. I'm like so proud of you. That was really
so impressive. I'm so proud of you. Yeah, totally.
Because you're still kind.
Yes. Yeah. Right. You're not just a blank slate.
Somebody said having difficulty even seeing a client remotely. Yeah, remotely is hard, although sometimes they can take you to places with their phone that you wouldn't get to be able to do with the office. But there is a different, like, a feeling and quality of in session, I think.
Yeah. With the fear of possibly overdiagnosing, because lots of people have intrusive thoughts, I think that's when you get into more of the sort of diagnostic questions of how much of your day is spent on this? How much does it interfere? Are you doing anything to neutralize it? Because most of us, when we have intrusive thoughts, we don't neutralize. We don't do anything to counter them. We either don't even notice them most of the time, I think, or we just say, oh, that was weird, and move on. And so I think it's what happens after you have the intrusive thought that would help you distinguish and avoid the overdiagnosing.
Somebody said when parents are reinforcing this at home, we're going to talk about that. Yes. Plug for myself. I run a parent class on helping parents decrease their accommodations based on the SPACE model, if anyone knows what that is. So you have to simultaneously work with the kids and their exposure, but work with the parents counteracting what you're doing at home. And then the scripts being really extreme. Some of the imaginal scripts can be really extreme. It can be hard to propose writing them in the first place. Yeah, it's really hard for the therapist to do it, and it's hard for the client to do it, but I just genuinely say this is really hard. This makes me uncomfortable too.
Yeah. The cleanliness one that we just got about your own contamination fears, or I guess high cleanliness standards and fear of doing contamination exposures. Honestly, that's where a supervisor comes in, because I would never did any of this stuff until I was in supervision. And then my supervisor would be like, okay, well, let's do this in preparation for the sessions, helping me. I ended up doing a ton of exposures that way. Sometimes we would even have, as part of our consultation group, we would even have someone come in and we would all do an exposure together. That's how the spider kind of played into it at my old clinic.
Carolyn asked, can we have explanation on describing to clients why we're not providing reassurance?
Yes.
Yeah. And that comes in the psychoed piece of that the reassurance seeking is a compulsion and that it doesn't help tolerate uncertainty. But that's why I playfully say, I'm going to be mean, Ashley, for a minute. And I'm going to make you feel more anxious because I need you to feel this. And so I tell them it's coming. I don't just stop reassuring and be mean, right? So you explain that the reassurance is making you not feel the fear and making you not be present. And you've been leading up to this. By the time you get there, the clients will kind of laugh about it. They understand that the reassurance is neutralizing.
Yeah. There was one about when OCD from parents led into abuse of children. Yeah, honestly, that doesn't happen a lot. I have had 2 cases where I was a little worried, and it wasn't malicious. It was just too much of the requiring the kids and the other family members to accommodate. But that's where you would bring in the family more broadly. And you would be really honest with the client about, these are the lines we can't cross with the kids. You would tell the spouse that, or other family members. I had a client who had several family members, including her parents, living in the home. So we would include them in the treatment too. And just say, if there's certain things that the client is requiring of the kids, having the other family members act as a little bit of a buffer and just make the guidelines around that really, really clear.
Daniel said fear of not doing them in the right order or with the right intensity. I would say throw that fear out the window because just use your general therapeutic knowledge. If you've hit too high in the intensity, you just back down a little bit, but you'll feel if it's too high, you'll feel if the client's not afraid. And inhibitory learning says it doesn't really matter what order you go into,
right?
But it's collaborative. So the client usually knows, yeah, I could start here. Sometimes the client will want to start too high and I do peel them back a little, but usually they'll say, I can go a little higher than you're proposing. And I say, okay, yeah. So throw that fear out the window, I think.
Yeah. Caitlin, you said something about the barrier would be the liability, i.e. fear of needles. Can you explain that one a little bit better so we can answer it? Oh, do I even want to know where to get a therapy tarantula? PetSmart, Petco, a pet store. That's where we got ours. We had Rosie. She was a rose-haired something tarantula, and then we retired her when she got too old, and we got, I think it was Charlie or Chip.
I love that Alma said that contamination would be hard for you because of your high cleanliness standards. Good. Own that. Like that is who you are and that is part of you. And you need to know that. And if you ever decided to do the work, you would just own it. You would say, this is hard for me. And Julie said, this is really needed. It really is. I mean, I have a 10-year-old and a 7-year-old, and they don't drink from each other's glasses. They just don't do things anymore. So that the needle, I mean, I just went and grabbed this, this is a horse needle, so it's huge.
Oh, yeah.
And we play with this all the time. I could pull out all sorts of stuff. I don't have any knives in here. Do you have any knives in your office?
No, but I have sharp scissors.
Yeah.
I mean, I have a butter knife.
Yeah. So it's informed consent. It's explaining why. It's explaining what you're doing and what the purpose is.
And it would be really gradual too. And the client and the parent would know when it's happening. So she might start out with this, where you uncap this part and just use this bottom part without the needle showing, right? And then you would say, okay, that's what we're going to do this week. And we're going to practice sucking liquid up in and out. I once brought hypodermic needles and I had a client inject into fruit, just water into fruit, just so she could practice using it. There's also pens that you can buy on Amazon that look like needles. that you write with.
Mhm.
And so I was a college student.
I'm just
so
gonna play with this. I have to put it
I
away.
know. And so I would have her, or highlighters. So I would have her use that in
Yeah.
school while she was
Yeah.
in college. So you're
And-
right. It's informed consent.
And I think you're also saying it's just scary to have those in your office. So then have a kit, have something with a lock on it, or only bring it in when you need it.
Totally.
Right. Yeah, absolutely. You may not want to have, I don't have any weapons in my office. So yeah, be smart. Yeah. Thank you guys. Okay. And if we missed any questions in that, like every barrage of statements, then type them back out when we do the question out and answer part later. Okay, so this is just a quick synopsis, kind of what you guys said. I wonder if we hit some of these, but they did some research polling therapists of what their negative perceptions were of doing exposure. They said they were afraid, this is really common, they were afraid that the client would drop out or stop prematurely, that they would get worse during the exposure because the anxiety would be high, or they would worsen after, that they would have a panic attack, pass out, or lose consciousness. I've never had anybody do that. Well, I've never had anyone do any of these things. Let me make sure. Yeah, no. Concerns regarding informed consent. And again, that comes with your comfort of talking about it. Needing certainty regarding OCD. Oh, a lot of you said that. Like, what if it's not OCD? What if I'm diagnosing it wrong? Again, seek supervision there. But exposure is good for everything.
Yeah.
I do exposure
I was
for
thinking the same
social anxiety, for even you can do exposure for depression. Like exposure is, there's the transdiagnostic, like exposure to all affect is good. Concerns about doing exposures with things that are objectionable or disturbing, like a needle or a knife or content like that. It's hard and strenuous. It is hard and strenuous. It's like you're tired afterwards. And then feeling not fully trained. I'm just going to really quickly go over this, but they did collect some data on 277 therapists who use ERP to see if it's true, to see if there are negative outcomes, and what were they afraid of. And the data showed that therapists are more willing to do, or that they're least willing to do exposure involving weapons and sexual content. And also, if they're going to do contamination, they're less likely to want to do any kind of chemical. What they showed about the actual outcomes was that 4.2% of those therapists had a negative outcome in their entire career, and 0.004 per year. But what those outcomes were, there were 6 of them involved clients, 13 involved therapists. And the client ones were things like the therapist got in a car crash, unrelated. They had a bed bug infestation, unrelated, although that might have been their fear, right? But unrelated. And the police were called because they were at a park, hanging out at a park. And they were like, what are these 2 men doing at a park? So, that's not good. The therapist outcome included the therapist getting injured. One of the patient's family members complained, and there was a police report. But the injury were a youth with autism who kicked the therapist during an exposure. That could happen. The illness was a stomach bug. The patient's family member complaining, or whatever that complaint, to me is an informed consent issue as well.
Yeah.
That if it's the direct family, the parents, they should know what's going on. You should not ever be doing these exposures without the parents knowing what and why. And then also, if the child is really aware of what's happening, they can also explain and advocate. So there were no negative outcomes involving harm to self or others, or exposure to sexual content. None, which is everybody's greatest fear.
Right.
So.
And to be clear, like, we wouldn't watch pornography with our clients.
Or bring a gun into the session. We don't do anything crazy.
There are definitely
ridiculous
things that are, and to Ashley's point, when Caitlin, when you asked about bringing things into the office, bring them in and then take them home again.
Mm-hmm.
Right. But we can do exposures to the sexual fears by looking at Hannah Anderson online clothing where kids are just, wearing clothes, right? And then having this thought, like, there's a chance I'm looking at this because I'm a pedophile. But we wouldn't look at actual pornography with our clients or anything like that. We wouldn't do anything illegal or completely immoral.
Yeah. Anything that would, cross that line.
Yeah.
So somebody said something about going too slowly in the comments. And so this is the most common thing that I saw when I was supervising interns and postdocs, is that they would come in, therapists would come in with cases that they've been treating for months, but hadn't begun exposure because they thought it would be too hard or too difficult. And they were still trying to boost up those coping skills and get the kid ready. To me, this is denying the client the most active ingredient. It's like saying, let's strengthen your eyes before you start wearing your glasses. So it is the most common thing. And I no longer hesitate to dive in. I think that first session instills hope and confidence, and it makes them think that treatment's going to work. And it takes us right into what is the most effective part.
There's actually a good question here that we should answer. Okay, the question is, in addition to good informed consent, do you have some type of supplemental liability insurance? No, is the answer to that
because
question.
It's evidence-based.
Yeah.
Right. So we're following a practice that's evidence-based and science-based to work. So we just, in our consent, explain what we're doing to them, it's what we're doing in therapy,
right?
And why we're doing it. And then if you were ever to come up against a complaint, you fall back on that you're following this treatment. Right. So it'd be similar to a trauma therapist being called out for making somebody relive their trauma over and over. And you'd say, well, this is what the treatment model says.
Right. Right. And there's data to support it. The one thing I did have a supervisor tell me was, if you're going to go somewhere with your client, you either drive yourself and meet them there, or they can drive you, but then you are taking that potential risk into your hands. You can't drive your clients. That's what I was told. So if it's, so you kind of decide what you're going to do. You shouldn't be driving them anywhere, because if you get into a car accident, then you're liable. You decide if you're willing to be at risk but getting in their vehicle, or you just meet them somewhere. Yeah.
And I've never been in a client's vehicle, though I think a lot of therapists do, with panic disorder and agoraphobia of driving. I don't. And I also was trained in graduate school that before going in the community, you should get a separate consent signed. And I don't do that anymore, but I just have a conversation. We live in a small town. We might see people that, this might happen. How do you feel? That's the plan. So common therapist pitfalls during exposure are not encouraging the client to go far enough, to push themselves enough during the exposure, choosing the wrong form of exposure, maybe doing imaginal when you could do it in vivo, or vice versa. In vivo isn't really getting at the fear because you can't. Encouraging or allowing distractions where, you're doing the exposure and the client's like looking at their phone or discussing something with you, making chit chat. Providing too much reassurance. I put too much in parentheses because, like we said, you can be reassuring and supportive without providing OCD compulsive reassurance. There's a difference. Treating the periphery symptoms and not the core fear. So what I mean by that is, you really need to know how to design the exposure to get to the core fear. I think I gave an example before of somebody washing their hands over and over and over, but it had nothing to do with germs. It has to do with getting all of the soap off. So I would do the exposure about putting soap on the person's hand and sitting with it and leaving it there. I put soap in my hands all the time and never wash it off. Never. It just stays there and just blows people's mind. So making sure that your exposure is correct. Not addressing those mental compulsions, which are the hardest ones to address, just sticking with the behavioral stuff that you can see, and then forgetting to include family members. I just really think this is powerful to include family members. I think
break. Don't you think?
Yeah, I think so. I think we might break and do our small group and kind of skip this here. What we were going to do is act out for you guys some role plays of us as therapists making mistakes, and I don't think we have time for that. So we're going to skip that, take a break, and come back, and we're going to split you guys into small groups and have you practice doing some of this in terms of coming up with core fears, designing a hierarchy, et cetera, et cetera. So, okay. All right. The small group activities now. So hopefully you received through email the case examples. And I don't remember, were they called by their names or what did we?
Kevin and Hannah.
Kevin and Hannah. So if you can pull those up. And then what we'd like, we're going to have you break into small groups. That's going to be done for us, hopefully, where you break into small groups, and we want you to read through the case example, figure out the type of OCD, what their fear is, create the hierarchy. And we don't mean create a whole hierarchy, maybe a couple of items on the hierarchy or what your kind of goal is to work through in the hierarchy. And then design one sample exposure, like where would you start? It is helpful to think what is the top of your hierarchy is a good thing to think about as well. Anything to add to that? So I'm not sure how many groups there's going to be, but the way we'll decide who does which case example is that we'll have odd groups take
The first one.
Kevin, and the even numbered groups take Hannah. I think they're going to be numbered, right?
Yeah, I think so. Will they be? Hold on.
Yes, I've got it where we'll break out into 10 breakout rooms between 5 and 6 people apiece.
Perfect. Yes. So if you're group 1, 3, 5, 9, you're going to do Kevin. And if you're group 2, 4, 6, 8, 10, you'll do Hannah. Did I do that right?
Sure. And we're going to give you a little under 10 minutes. And then I don't know, do we just call, how do we bring them back? Or do you set the time limit for that?
I will watch it for 10 minutes and I will then bring them back at 10 minutes.
Do you want to do 10 or do you want to do a little
do
less?
7?
We're going to do 7.
Okay, whatever you want.
Just to mess.
And there's a handful of people saying that they didn't receive it. It was in the Zoom link email. So you did get it. You just have to go back to your Zoom link email.
Okay. Maybe give them 10 minutes because people might need to read it and find it and then read it.
And hopefully someone in your group can read it too, if you
guys
can't.
could just read it aloud to one another.
So we'll do 10 minutes and then we'll come back. All right.
All right, I'm going to send them off.
Thank you.
Actually, we can just look at the chat. Okay, let's just ask. Okay. Yeah.
Welcome back, everyone. As you're coming back in. Halfway there.
Hello, this is Doug.
Oh, looks like everyone's back.
People's back. Yeah.
Okay, good. Okay, so what we're going to do is we're going to open it up for discussion. And I know we've been using the chat so far, but I really would encourage if anyone wants to speak up and put their video on and actually speak up, that is great too. But what we'll do is we'll start with Kevin. And so for those of you that didn't have Kevin, this is what it looks like. So you're welcome to read through that on the screen. But for those of you that did have Kevin, if you can be brave and either speak up in the chat or really just unmute yourself or raise your hand and we will call on you and talk a little bit about what your groups decided, what type. Let's start with what type of OCD that he had or types.
We went with relationship OCD, and then possibly scrupulosity or contamination. With the piece with the hand sanitizer at the end.
Yes, yeah, I love that because there is a contamination component, but it is more likely to be about the essence of him and not so much about germs, right? But that is definitely contamination OCD still. I actually forgot that was in there. So thanks for pointing it out.
I think there's one more. I think there's one more flavor of OCD here too.
Oh, yeah, I forgot the sexual orientation piece as well.
Exactly.
Yep, good. Anyone have anything to add on that and the types of OCD? Or if you guys want to chime in on what are some things that you put in the hierarchy, which is a little hard. This is not an easy one, you guys.
We talked about like seeing and confronting the fear of maybe my wife isn't my soulmate or true love.
Good. Right. So through some imaginal scripts probably, or
without reassurance seeking or trying to neutralize the anxiety that saying that out loud may bring up.
Yeah, for sure.
Someone else also brought up spending time one-on-one with a woman or man and kind of in a more in vivo experience too.
Really good. Yeah, because that's common. People will try to avoid being alone in a room with somebody that they might find attractive in some way or that OCD might latch onto in some way.
Right.
Good. What else, guys?
We talked about potentially looping in the couples therapist in just to get some more clarity about their treatment goals and collaborative piece. And also like limiting the agreements to limit certain behaviors, like putting boundaries with his wife not being willing to engage in these long conversations and maybe the therapist not, responding to his emails. I mean, clearly this would be, explained to the client, but
right.
Sort of increasing that tolerance for intolerance.
Yes, I love that. I mean, I love that, especially the picking up on the couples therapist, because well-meaning couples therapist is going to go, yes, absolutely, these things happen, and discuss, but marriage is hard, right? But decreasing the reassurance and that role that poor couples therapist is in. And then I bring in the partner. So I would bring in the wife and say, here's how you're going to respond. Here's how much time, and make a plan together for how to decrease the reassurance that the wife is also providing. Mm-hmm. Okay, any others? What about oh, go ahead. Somebody was gonna.
I was curious about the him going to the bar.
Mm.
In some ways that would seem like an exposure that he's doing for himself, but it's almost like reassurance seeking. And so yeah, I was trying to figure out how to factor that in, because you'd want him to expose himself, do exposures without it being reassurance based, I guess.
Well, if you read there, and that's a really good question, because a lot of people will do these like tested out behaviors. Like I actually had a client once, this is totally unrelated, who burned himself because the fear is, what if I burn myself? And he finally eventually did touch with burnt himself. Like people will test these things out. So if he's going to the bar, is that an exposure? Well, but look at all the look at all the compulsions he's engaging in afterwards, right? So he's probably ruminating because it says he feels awful. He's doing list writing and Googling afterwards. So the exposure would be more, go to the bar, notice one person that you find is attractive, write down 3 or 4 things physically or the personality that you thought were attractive. Right. And then you're not allowed to ruminate, seek reassurance, or Google afterwards. Yeah. So we take what they're doing and do the response prevention, cut out the compulsions, and then increase the intensity. So that's a really good thing that you picked up on that, because it's common. People do these tested out type things, but then it's not really an exposure because then they're trying to make it okay afterwards. Right. Good. And then what about this badness inside and the hand sanitizer thing? Cleaning himself all over with hand sanitizer. There's a popular teen book. It's fiction where the girl is drinking hand sanitizer to get rid of her badness. That's where I came up with this example. And she ends up hospitalized. Yeah.
So is this the exposure to disgust that you were talking about? The feeling of disgust?
Good. But possibly you'd have to really get at the core fear there. Is it disgust? Is it fear of making other people finding out that he's bad, or affecting other people with his badness? So getting to the core fear of what that is, and then obviously decreasing the response prevention and the cleaning. But if the fear is people will find out I'm a bad person, maybe it's writing that down on a piece of paper and carrying it around with him without engaging in any cleaning or sanitizing. This is where you have to be very, very creative to figure out what is that fear and how do we do an exposure to the fear. Maybe it's, I can't be near people unless I've sanitized myself that morning. So, okay, don't sanitize yourself and then come sit really close on the couch. Let's sit like this. See if I turn into a bad person, right? Or see if I find something out about you. Yeah. Ray, you have your hand up.
Yes, I just was curious about how you deal. This goes back to the bar again, and how you're dealing with the fact that he goes to the bar and he drinks, and then he's perhaps disinhibited, and then he's doing things that actually compound the situation because he's drinking. So I didn't hear any comments about how you might want to deal with that.
Yeah, do you work with substance use somewhat? Is that why you picked up on it?
Yeah, a lot. and I also know that a lot of bad things happen at bars.
Yeah, right.
So,
right.
So you could have a whole protocol here that gets undone by the fact that he's going to a bar as a way of coping.
Right.
He's maybe meeting somebody attractive or flirting, and it's actually encouraging all these distorted thoughts that he's having about his marriage.
Exactly. Well, under the influence.
Right.
It's kind of the question of, do you leave somebody who's suicidal alone with a knife, right? It's just
Exactly.
it's a bad situation. And interestingly, like this is why I asked you, did I write that he drinks? I don't know if I wrote if he's drinking or not. We would assume he is.
No, you just said he goes to the bar, but I would assume he's not drinking ginger ale. But.
And people actually, interesting little caveat, when they imbibe any substances, whether it's drugs or alcohol, OCD goes haywire, because then you doubt your reality of what happened. Everybody has gone and had a couple of drinks and the next morning go, oh God, what did I say?
Right.
But take OCD and latch onto that and go, did I cheat on my wife? Did I murder somebody? What did I do while I was under the influence? Because I can't quite remember. Even if they only had one drink, everything's a bit fuzzy, right? So yeah, I would, well, it's interesting because I have actually had people treat it like a hierarchy, like, you know, well, now I do want you to, you know, somebody who smokes marijuana recreationally, do this exposure, you know, after smoking. But so you'd have to assess what is the level of their use and is it healthy or not healthy, right? I think in this case, there's no benefit to him drinking, and it's probably a bad idea, right? The person I'm thinking of in my head would sit at home with her husband and maybe smoke marijuana and watch a movie and then have all these OCD spirals. So we used that in a positive way, right? Somebody going to a bar is not putting themselves in a very good situation necessarily.
But I think you'd have to assess like what's happening at the bar. What are the compulsions happening maybe related to the bar? And then you would start piecing those things apart.
And I wouldn't, it's funny, I think you pick up on it because of the work you do, because I wouldn't have picked up on it because a lot of my clients, this is a thing that happens. That's why I wrote it in. And it's more about the uncertainty of the situation than the behavior that's happening is unhealthy. Right. So we might start with a more certain situation of like talking to your coworker where you are not under any influence versus going to the bar and being under an influence and doubting yourself. But truly there's uncertainty. Like, in fact, I use that example sometimes. Most people don't cheat on their partners when they're drinking at a bar.
Right.
They just don't. Right. So it's accepting that uncertainty. So yeah.
Thanks.
Oh, that's a good comment in the chat of this is an intersection between ACT and ERP of I would like to have sex with this person, but I'm choosing to be faithful. And that's absolutely true because there is a feeling. And when to Ray's point, when your inhibitions are down, you are going to notice those other people, but yet you choose to stay in your marriage. You choose to be faithful. There's that great couples therapist quote of every single day you choose to commit to your marriage.
Right.
It's not that every day you love your partner. It's that you commit every day.
Yeah.
Yeah. Any questions about Kevin before we move on to Hannah? These are really good thoughts. Okay. So Hannah, for those of you who didn't have Hannah, here is her write-up. Who wants to share what they thought were the core fears and the types of OCD for Hannah? Because Alexia and I reread it over and over.
Yeah.
What is the core fear, you guys? Go ahead.
All right, I'm going to start my video. We talked about the harm fears, harming others, the hit and run fear, fear of hitting someone, reassurance seeking. I mean, it didn't really go into this, but I guess you could make an argument for scrupulosity if she's thinking like, what kind of a person am I if I hit someone? What does that mean about me as a person?
Right.
About my morality.
Yep. Good picking up on that. And that's a little more subtle. Like it's very clear hit and run OCD and harm OCD style, but there's this priding herself on being a good student, good person, good employee, and conscientiousness that I just think sometimes there's a tinge of that in the harm OCD of what kind of person am I at a moral level, right? Why would I even question if I hit somebody and did I want to?
Yeah.
So what does that mean about me?
The very existence of the thoughts sort of suggests sometimes to people with OCD that oh my gosh, by the fact that I had this thought, maybe it means I am the kind of person who could do this,
yes,
or wants to do this somehow.
Yeah, good,
exactly right.
And what about some hierarchy or exposure items? Like a social experiment waiting to see who's going to step up.
Well, we had a discussion about I guess two points of entry, that either decreasing the retracing her route or decreasing like the specific checking behaviors of like the taking pictures and checking the car and stuff like that, decreasing time, checking, maybe unfollowing the Facebook pages, things like that. And then
Good. So you really zoned in on all the response prevention to do, which is excellent, cutting out all those compulsions that are providing reassurance.
Well, and we also talked about the possibility of changing. So she has this mantra compulsion saying safe, safe, safe. We discussed changing that to be more self-compassionate. Because it seems like she is worried that she's causing harm. It seems more like she's saying safe, safe, safe for other people. Other people are safe. And so we talked about potentially focusing on herself and having more self-compassion.
Yes.
Yeah, exactly. Yeah, you could always have her repeat. There's always a chance that someone could get hurt. Yeah, you could have her record that and listen to it while she's driving around. Yeah, or just have her say that, or even the example from the video, a simple word like maybe this could be true, maybe this could happen.
So I think that it's interesting though, because there's two ways to go, because you guys are saying go self-compassion route, which is like you're having OCD, this is a hard experience, this is your anxiety, self-compassion, but we don't want too much reassurance so that everyone else is saying, like Daniel said in the chat and Alexa saying, increase the uncertainty. I think that the self-compassion route almost comes later.
Yeah.
When the person gets to the point that they can handle the uncertainty, and then they're really trusting themselves, because really the ultimate goal here is to trust yourself that I'm not the kind of person that's going to go to a bar and cheat on my spouse, or I'm not the kind of person that's going to gleefully run someone over on the road. So if she gets to the point where she's feeling more certain in herself, then I'm more comfortable with her using a self-compassionate type statement. But in the beginning, I would want her to go, like this comment, there is a chance I could have hit somebody. I'm okay with, there's a chance I could hit somebody, or I could have hit somebody, but I don't think that I did, but there's a chance. That's kind of something that I introduce later on when people are starting to like straddle both worlds of I see OCD and I see reality. So I have them say, I don't think I hit someone, but it could have happened. So, because that's kind of how we all exist.
Yes, I think the therapist should be in the car with the person. To answer that next question, we were discussing if anyone should or would be willing to get in a car and go on a drive with her. That's how I understand hit and run OCD to be treated. You have to be sitting next to the person, and because they're going to want to drive around, they're going to want to stop and check, they're going to want to, and you want to keep them focused on going forward. You want to keep saying to them, it could have happened, but you have to keep going. You have to take that chance. Maybe you just hit someone, you can't stop and check. And you would set up the rules for what that one exposure session would look like and then build on it. But yeah.
And I've treated it without, and it's worked, but that's the most effective way to do it. That is the most direct, go to it and just do the exposure with them. Do the exposure. But I'm liking the jokes / not jokes here from Pete about driving over speed bumps and mannequins, but literally we do want to do over learning.
Yeah.
So driving over things is a good idea, like drive over a box in your driveway. A big fear is backing up. So like having something that you're going to bump into when you're backing up. A lot of people will cover the rear view mirror so they can't look back behind them and can't check behind them. Roundabouts are terrible in Bend. We have like thousands of roundabouts. Don't let people go around and round the roundabout and keep going back. So making rules, what they're allowed to do or not allowed to do. Any other comments or questions here? Driving over the medium. That's good. Driving at different times. So with poor weather conditions at night, driving in different mood states. So I've noticed that people, if they're angry, are more afraid, or if they're distracted or tired, they're more afraid that they did something. And then I do think imaginal exposure is really effective too. Writing scripts about this and pulling in that scrupulosity component of, I thought that I hit someone, but I was late for work and I don't really care if I hit them. I'm just that kind of person. So I just kept driving, might have hit them. I think it could have been a child, but I just kept going. Right. And like really making it dramatic and getting at that feeling. Yeah. How do you balance? If the person has lots of rules for themselves, I think that's kind of getting at more of OCPD, like obsessive compulsive personality disorder. But I think with just OCD, their rules are just related to their compulsions.
Right.
So they can be completely not rule governed in every other aspect of their life. They could be sloppy and messy and late and not, not organized and not very scrupulous, but be very obsessed and worried about one thing. So I haven't really found that to be
I haven't either, but also if you're doing ERP and they are sort of rule driven people, then you might be actually doing homework assignments or doing ERP to that, right? So it would be like, you can't go back and rewrite something. You can't reread things. I'm going to make everything in your office askew and not let you fix it. So you might actually, you're not creating more rules. You're tapping into the thing that they're resisting.
Or make them be more in charge. So, okay, fine. You like me giving you these rules. You set up the parameters for the exposure. You set this up. You design it. Yeah. Okay, great. So we're going to move in. Oh, what we're going to do then, I forgot about this part. We're just going to read through these and have you guys put it in the chat. So maybe do you want to monitor the chat?
Yep.
And have you guys just type in the chat the core fears. This is like your pop quiz at the end. And then I'm going to talk about children. And I remember at the very beginning, I said autism. That's going to come up. And then we'll leave time for questions. So let's see. Okay. So, and I haven't read these in a long time, so I don't remember what they said. So here we go. Jenny has obsessive rumination over whether or not she has killed anyone. She frequently checks to look for evidence or to check for the body of her victim. It is hard for her to throw anything away or do any laundry because she's afraid if she gets rid of evidence, she'll be hiding the fact that she's a murderer. She repeatedly states, I couldn't handle it if I killed someone and then no one found out. They would never know what kind of person I truly am. She's always asking her family members whether they think she could do something awful to hurt someone. Recently, her fears have begun, including fear of molesting children or cheating on her husband. She refuses to be alone with any child, and if she sees a child, will spend hours questioning if she was alone with them for too long. She also frequently checks with her husband to see if she thinks he has cheated on him. Whenever her fears get too overwhelming or she's unable to check if she committed some kind of crime, she'll experience panic-like symptoms and describes a terrible feeling of shame and hatred. So in the chat, what are the core fears? We're not so much talking about the type of OCD, that's part of it, but what is her worst fear?
Okay, so we got, I'm a terrible person who would murder people, molest children, or cheat on my husband. She's an evil person. Yep.
Yeah.
She's a bad person.
That's the core
fear. I'm capable of causing harm to others.
Yes.
Yes.
Good.
Great.
Good. Exactly.
She does bad things.
She does bad things. And I think, whoever said like, I'm a terrible person really just kind of gets to the core of it.
Right.
What if deep down I'm evil? What if deep down I'm a bad person? And, you have to have try to connect with people. Like you maybe never have been afraid that you would murder somebody, but I think everyone has been afraid. What if I'm not a good person? This is a thing that we all think in some ways. Benjamin is a 9-year-old boy who has to repeat activities over and over. This takes up much of his day. And so his parents try to help him by doing things for him so he doesn't have to redo them. Benjamin says he has to repeat things like swallowing liquid, entering a room, putting on a seatbelt, putting on shoes, turning off his iPad. He recently explained that he used to repeat things 4 times, but lately he can get stuck doing it over and over until it feels done. He also has behaviors which involve his body. He says they're not a problem, but his parents are concerned they will attract negative attention. He has to avoid touching objects when walking because if he bumps an object with one side, he feels he needs to go back and bump it with the other. He tries to sit exactly in the middle of the chair so his body feels even. What do you guys see there?
What's the core fear?
Symmetry.
Can't trust himself. He won't be able to handle the feeling of not repeating.
That's good. Yeah. And these things are things that you just talk through with your client till you've really nailed it.
Yeah.
And sometimes it might not be till 6 months in where you're like, let's refine a little bit the way we're wording it. Right. Like the self-harm one, I once had a client that it was the fear of being a bad person, but it was also the fear of hiding that, deep down hiding that from people. Okay, I'm actually gonna bypass these and go to, just because I want to leave time for questions.
Okay.
Yeah?
Yeah.
Okay. Okay. Okay, so this is another quote from Edna Foa that I found to be very simple but profound, that everything is less with children. So you're doing the same things, but you're doing it in less intensity. You're doing it slower. You're just being aware of the child being a child. So what is different about kids and teens? First of all, children often, they cannot report the core fears or the content of their obsessions, and that's okay. I have clients that are 3 or 4 years old. They don't know why they have to open and close the doors over and over. They just don't know, but they feel uncomfortable. So what you need to pick up on is the fact that they're anxious or uncomfortable in some way, and that the compulsions help them to feel better. We don't need to know the why. The exposure still works if we don't know the why with children. The rate of treatment can be faster or it can be slower. It just depends on their motivation. If the child is motivated, it actually goes much faster because the behaviors are less ingrained, actually neurologically ingrained, but also habitually. And usually the therapy tends to be more behavioral. It's less about the core fears and more about, hey, let's not open and close the door and see if you can tolerate it. Parents are a huge part of treatment. And my goal when I'm working with the family is to replace myself so that I am not the person managing this, because likely if you have a 3 or 4-year-old, for example, with OCD, this is going to be popping up throughout their life. That's just likely. It's not necessarily true, but it's likely. So you want the parent to go, oh, hey, you're having this thing. Let's turn it into exposure. Not let's call Ashley because you're having this thing. So they need to have really, really be well-versed in the psychoeducation about ERP and OCD, and they need to be really involved. We talked about this already. They carry out the homework in between sessions. Having them present can be helpful or unhelpful, and you need to read that. Actually, during COVID, I hated having the parents there. The kids didn't want to do the exposures when the parents were sitting next to them, so it was really interesting. But in my office, I do have parents usually have the kids do the exposures with me, then I bring the parents in and do it, but it just depends on the kid. Sometimes the parents can be a prop for exposure and they don't know it, but because so many kids have this fear of their parents dying, usually the mom, poor moms,
Always
I
moms.
don't know. Then I have parents come in. I had one mom who really just didn't have a lot of compassion for her daughter's OCD and definitely didn't have any understanding of her daughter's OCD. So we just had mom sit there on the couch. Well, the client looked at her thinking thoughts of mom dying without doing her compulsion, which was to blink. And so mom's just cluelessly sitting on the couch while her daughter's looking at her thinking about her dying. And it worked. So some things that we think about when we're treating kids is we like to externalize the OCD. We like to help them think about the OCD like a bully, and we're going to fight back together against the OCD. We're going to argue with the OCD and say, I don't have to listen to you. We practice arguing with it, not arguing with the logic. We never want to argue with logic of OCD and say, no, that won't happen, because we just say, I don't have to listen to you, go away, right? Accurate exposures can be hard if the kid can't say what they're afraid of. So if the kid won't go into a public restroom, is it germ related? Maybe, but I've had kids who are afraid that if they touch the disability bars in a bathroom that they will become disabled. Or I had a child who was afraid that the toilet was a portal to another world. You don't know why they won't go into that bathroom sometimes. So sometimes if your exposures aren't working, you need to figure out how to hit the mark more accurately. And then motivation. Obviously, some kids are really motivated, but a lot of them are brought there by their parents and they don't want to be there. So you really need to make it fun. You need to use rewards, use games, get people involved. I mean, I'm a huge proponent of asking kids to do something hard means they get rewards. It's scary and it's hard. So I don't recommend using any consequences for engaging in their compulsive behaviors. There's some specific circumstances where that does happen, but it's later in therapy. It's with older kids, and it's like the teenager plans that out. Like, okay, if I ask you 10 times, then I'm going to turn in my phone for 5 minutes or something like that, because they agree that they need a motivation. Okay, let me just give one case example really quickly. So 7-year-old girl with OCD related to contamination, tons of distress because she would avoid using the bathroom for an entire day, having lots of issues, health issues related to this. needing to change her clothes and wash her body every time she used the bathroom. So every time you go to the bathroom, changing your clothes and doing full body wash, needing mother to wipe her after she used the bathroom, and mother needed to supervise her hand washing to make sure she was doing it correctly. And then unrelated/related, lots of externalizing behaviors of oppositional behaviors and aggression in the home related to feeling scared and out of control, but also because there wasn't a lot of consistency in the parenting. So therapy involved tons of rewards because her motivation was completely non-existent. It was like negative. Lots of education to the parents about how they were reinforcing some of these behaviors by monitoring her hand washing and wiping your 7-year-old's bottom after they go to the bathroom. Lots of over learning, like touching things in the bathroom without washing your hands afterwards, things like that, and decreasing the parental involvement. I did home visit here because the parents couldn't push to the top of the hierarchy. So I spent like 3 hours at this house one day. But she was able to get rid of all of these behaviors and go back to everything kind of as normal behavior. And I had a follow up with her 2 years later, it hadn't returned. And so again, with this case, I think the reason why it decreased so significantly is because it was a new behavior and she was young, right? And then I'm just going to talk about this, but I don't think I'll go into my case example, but because somebody mentioned how parents can reinforce it at home, and you could see that in this example, the parents were reinforcing it at home. There is a parenting model called supportive parenting for anxious childhood emotions. If you guys know about it, please put it in the chat. I'm curious if you've heard of it. Developed at the Yale Child Study Center. And the treatment model was designed for kids who don't want to come into therapy, but the parents are like, I don't know what to do. I don't know what to do. And so training the parents to decrease slowly their accommodations of the anxiety. And so the way I explain it is you're helping the parents learn to support their child and support their child in their experience of the anxiety, but not support the anxiety and not make a place in the family system for the anxiety. The research shows that it decreases the stress and conflict in the home, it decreases the parent's sense of hopelessness, and it decreases the child's anxiety without the child ever coming into the office. So I've been running these classes for about a year now, and then I just collect my own qualitative data and quantitative data, and that parents all report that it decreases their sense of hopelessness and sense of overwhelming of I don't know what to do. Everybody reports that it decreases the anxiety, but nobody ever says my kid doesn't need therapy anymore. Right. However, because we have wait lists that are like a year long, when I will reach back out to parents who took the class, I've been noticing that the younger children those parents say we don't need therapy anymore 6 months later, because they have changed their family system. And so I think that when parents are not accommodating their child's anxiety, inadvertently, the child is doing exposure to face their fear.
Sarah asked, is there an age range for space?
No. Yes, no. The youngest I have worked with is 3. I don't know what Dr. Leibowitz says, but the youngest I have worked with is 3. And there is also a failure to launch program. So it goes all the way into early adulthood. I'm not trained in the failure to launch program, but it's brilliant, right? So this is like, especially if your kid has failure to launch and OCD, and you have a child who literally doesn't leave their bedroom because their contamination fears are so bad or their social anxiety is so bad. And this space model is not just for OCD, it's for all anxiety. However, it has to be severe anxiety. I get a lot of referrals for this class. Like, my kid is kind of anxious. It has to be severe anxiety such that it has changed the whole family system. Okay, I'm going to skip that. That was just a case example, but let's talk about dual diagnoses really quickly, and then I'm going to hand it back to Alexia. Really common for kids to have dual diagnoses of tics or Tourette's, and actually in that triad can be OCD, Tourette's, and ADHD, the impulse control kind of neurological diagnoses. So that's something to think about, that OCD and tics can overlap to Tourettic OCD. Autism, which was the question before, there is a high comorbidity, especially in autistic children who are more high functioning, so they have lower severity of their symptoms. There tends to be a lot of overlap because there's a lot of rigidity and inflexibility in both diagnoses, and also a need to control things to feel comfortable and to make sense of your world. So there's a high overlap there. But I said earlier in the program that it is really common that other practitioners refer kids to me and say that they're that they have OCD when there really is no distress related to the behaviors. It is a preference. It is a rigid preference, but it's a preference. It's not like I'm really scared if I don't do this thing, something bad will happen. It's just that I want to do this thing. And that's a distinction. And so getting at the function of the behavior is extremely important. Treating children with comorbid OCD and ASD requires a much slower approach because the tolerance can be lower, the flexibility can be lower, the motivation can be lower. So it's important for the parents to understand that this is going to take time, but it can still be effective. And actually, sometimes children or adults with autism really like rules and structure. So actually, sometimes this makes sense because the treatment is very logical, right? We're not going to talk about PANS or PANDAS because that is an entirely different presentation, but it's something to know about too, which is related to strep or some kind of infection that was the origin of OCD.
Okay. So very briefly, about 70% of people will benefit from ERP and or medication for OCD. So there is research to show that you're changing the sort of neural pathways of the brain either by using medication or ERP. I like to start with ERP unless, like Ashley described earlier, someone comes in and their symptoms are so severe, I feel like after a few sessions we're not making much progress, then I might recommend medication a little sooner. SSRIs are the most effective for OCD, but this is, and as add-ons, really small doses of antipsychotic medications can also help augment the treatment. But what's really important is that the dosing can be very different than that for depression or anxiety. Sometimes it's twice as high, sometimes it's even higher than that. So maximum dose, for example, for Prozac or fluoxetine for depression might be 40 milligrams, but in OCD, could be 60 or 80. I actually think I have somebody right now who's on 120.
I think I have somebody close to 200. And
yeah. So if you send people to more general practitioners, they may miss that part. And so then the client or you may think that they've failed a medication trial when in actuality, they never went high enough. So I always recommend going to a psychiatric prescriber who has more specific knowledge of this. Other treatments, we're not going to talk specifically about these, but here they exist. ACT has been kind of an add-on that I've been doing mostly around the pure OCD stuff. One of my colleagues who's well-versed in ACT basically said for some of the obsessive thoughts, he thinks ACT works better. And I've started to see some of that too, but it's not my area of expertise. I would love to get more training on it. Ashley mentioned self-compassion therapy for OCD. And then there's inference-based treatment. What do you want to say about that?
Inference-based treatment is a newer, I actually think it's been around for a while, but it suddenly hit in popularity and a lot of people are picking up on it. It needs more research support, but it's more of a cognitive model. And what I do like is it focuses on that doubt of, can I trust myself? And can I trust reality? And I've used it with clients who've been through exposure with me for multiple years, which is rare for me. My clients are short-term and they're still not accepting and trusting. So I will use some of these strategies.
And then when outpatient treatment isn't enough, indicators of poor response to ERP on an outpatient basis is sometimes it just is so overwhelming. Clients will come to your office. They have so many treatment targets. It feels like you're not able to make progress on anything. Their level of severity makes functioning very poor, and they could really benefit from a high dose of treatment. And then they're going to still have to come back to outpatient to continue to do work or maintenance. Sometimes clients with poor insight have a poor prognosis for treatment. Getting them into a higher level of care might also help them get medication on board faster, which could be helpful. And then, of course, there are different levels of care, which I'm sure we're all familiar with.
And there are some good options in Portland for those of you, well, for anyone really. I mean, like there's some, oh, you stopped our video.
Oh, sorry.
Some partial hospitalization, day treatment type programs.
And then these are some newer areas currently being researched. Actually, TMS has been around for quite a while now, and I think it's got some good data on it. I don't know a lot about it, but I think we're going to end here. These are some resources. You all have access to these because you have the slides, and then we can open up for questions for the last.
And I would just
10
put a
minutes or so.
plug for two things. One, we mentioned all those books, but the podcasts I do recommend those a lot to my clients. They're really a good mixture of science, but also people telling their own stories, and people find that very validating. And then also, if you're trying to find an OCD therapist and you're not sure who to refer to, go to iocdf.org and go to their directory, because and there's a ton of you guys in Oregon. I looked the other day, it's like doubled recently. So people on there have been certified to have this treatment training. So if you're like, I'm over my head, I want to refer, I want to consult, that's where you would find us.
Yeah. So, and for those of you who want more specialized training, you would get that through the BTTI Institute through the International OCD Foundation, and that link is up there too. Okay, little question.
All right.
Okay.
All right. Here is the verification code for today's webinar. It is OPA 120123. OPA 120123. Anyone that wants to gain CEs from this webinar, you will need that code to use in the survey that's going to be sent to all attendees. Please watch for it. It will be sent to you by the end of day today. Any final questions from anyone about continuing ed, or any last thoughts?
There's a couple questions in the chat. Are we able to answer those as people drop off?
Sure.
Okay. The question about OCD and ASD, and if the child's not distressed by the OCD symptoms,